Respected chairperson and my dear colleagues, good to see Sunday morning, 9 o'clock. Surgeons are there, Dr. Dilip Kaur, so I must congratulate all those audiences are there who has come on Sunday morning. Dr. Pani, good morning. And I must welcome all my panelists who are great and who are stalwart in their own field. Starting from surgical oncologist, medical oncologist, radiation oncologist, full house. So I am fortunate enough to get a full house. So I do believe it's a good discussion will be there. Now, to begin with, I must say like why we have chosen this topic of a locally advanced gastric cancer is because of this is the third most common cancer which we are getting in our OPD. And the approach to this cancer is different when the patient approach to our different faculties, and at the end of the result, at the end of the day, we all want the best to the patient, but since there are different approach are there, so we thought of like why not to get in from the panelists, from the audiences, what best can be done or why their approach is something different. And I must request to all my panelists that they must come out with whatever the practical things which they are getting in their OPD based on their evidence, yes, definitely, but why the approach is something different. So we covered this 40 minutes with the 3 cases, and these are all our own cases. So let us see how our panelists, and I must say I will engage my audiences also to give their inputs, like how they approach. So to begin with, it's not working. Okay. So this is a 57-year-old female patient with fullness and occasional pain abdomen and no significant past history and family history. And on examination, she hasn't got any mass and no pelvic deposits are there. So so how you will proceed? So I may say this case is with a surgical oncologist. So to begin with, I must say my surgical oncologist colleague, Dr. Sao, how you will proceed with this case?
Yeah, good morning everybody. So since the patient has presented with some kind of abdominal pain and dyspepsia, the first thing I am going to do is put a scope, I mean upper GI endoscopy, and see what is there inside. And if there is a suspicious lesion, then obviously you need to take a biopsy.
So definitely an upper GI endoscopy and with the biopsy, and upper GI endoscopy shows there is a small growth is there in the distal end of the stomach, and you have taken the biopsy. And then?
So since if the biopsy is positive, that is adenocarcinoma of stomach, then we need to do further workup in the form of a local and distant disease mapping, that is CT scan of the abdomen, I mean whole abdomen, and NCCT of the thorax to rule out pulmonary metastasis. That is what we normally practice.
So the upper GI endoscopy, this is the photograph. I don't know whether you can able to see it or not. That's a distal growth is there, and which small amount of distal body of the stomach is also been involved. That's the endoscopy report has been there, and that's the CT scan finding. So I may request to my Dr. Salil. So can you please see what is there in the CT scan?
I could look out, there is a circumferential thickening in the distal part of stomach involving the pyloric part, and there is no, the outer line of the stomach looks normal, and there is no perigastric or
correct. So
perigastric, there is no lymphadenopathy. Okay.
Correct. Distal stomach, some thickening is there, and there is no nodes, perigastric nodes are there, and that's the finding of the CT scan, and that's a biopsy report has been there. So it's suggesting as an infiltrating adenocarcinoma of the stomach. So now my question to my pathologist, like, would you like to do an MSI in this patient apart from the whatever the routine investigation and the report is there with you? Would you like to suggest an MSI for this patient?
Actually, MSI panel is only suggested when you are having this poorly cohesive carcinoma. So that's for prognostic. But initially, if you do MSI, I don't know. It's,
Can you please be loud enough?
yes. Generally, we suggest for MSI panel. We
So,
suggest for MSI.
so
or
MSI
inverted-
is a mandatory for all the stomach cancer, or would you like to do in some special cases?
It's mainly done in case of medullary carcinoma and poorly cohesive carcinoma. So as it is a very poor prognostic cancers.
No, we are not. Are you suggesting a MSI for
Yes, we suggest
for any stomach cancer
stomach
biopsy
cancer,
proven? You will suggest in
it's
your
a-
report that an MSI has to be done.
Yes, MSI has to be done.
Dr. Srigopal, what's your and why you want to suggest an MSI?
I think in this scenario, clinical T2N0, I won't advise MSI
You won't advise.
from clinical therapeutic perspective.
So you have got a special conditions in which.
Yeah, in inoperable, advanced or metastatic setting.
So what's the take from Dr. Salili, Dr. Pani? Yes. Can you please?
Sorry, when you are contemplating the neoadjuvant chemotherapy, the data published that if MSI is high and you are giving NACT, the response and the outcomes are poor, so it is better to go for the upfront surgery than for the NACT. That is what I think Dr. Agarwal is speaking. Even if the FLOT regimen, even if they give the intensive neoadjuvant chemotherapy, still the response is poor in the MSI high subset analysis.
So what you are, if I can draw your conclusion, that you will be saying that MSI should be done upfront for the for any biopsy proven in a.
NSI in the neoadjuvant setting is required.
Sir,
We are not
I
doing
have one
off late,
point.
but
As
it is
per
required.
NCCN guidelines, MSI should be done in all the newly diagnosed
Correct,
stomach
correct.
cancer, especially those cancers which have intestinal type. And second important thing is we have known that MSI positive patients have less response to a 5FU based chemotherapy.
Correct.
So this is another thing which we have to consider in this situation. As per NCCN, you have to do irrespective of what cancer, what stage, you have to do all the newly diagnosed cancers. You have to do MSI.
So yes, it's correct. So as per guideline, we should do MSI in all setting, in all newly diagnosed CA stomach, we should do MSI as a part of evaluation. But routinely we don't do. We do in advanced metastatic or recurrent setting. But yes, as sir said, response to chemotherapy will be less when MSI will be.
So it will just add on to some IHC cost only, but yes, definitely you will be having an upfront information because you don't know after the report what is the coming out. So in one go you have got a privilege to discuss with the patient. So yes, Dr.
So
Saroj.
there are two aspects of doing MSI. One is you can biologically prognosticate the disease. I mean to say MSI high is associated with like intestinal type, early disease, low lymph node metastatic disease and overall prognosis. The other aspect of doing MSI, what like Dr. Chinmay said, if you are planning to subject the patient for a neoadjuvant therapy, then you should think about it. Because it's MSI high, then your response to neoadjuvant chemotherapy is obviously less, though the overall survival is better. So then you can plan for a upfront surgery if it is doable.
Saroj, I'm confusing. So we are talking about CS stomach. So early, locally advanced. So what is the role of MSI? So as of now, so MSI in stomach is only for a palliative intent. So we are looking at a immunotherapy. So the story of stomach cancer is different. And the colon. But I don't think, so if at all MSI high in a stomach, so are you not going to give a 5FU based chemotherapy?
No.
So-
The
So there is no such, Chinmay?
It is like this. There are two aspects. MSI age is associated with something which are favorable.
The association
that,
may be different.
That you can prognosticate to the patient.
So I must say that the interpretation of the MSI in the later aspect, that's a different story.
So Shubhashish, so tell me, so what is the incidence of high MSI in a stomach cancer?
Yeah,
20
it is
to 30%.
around 20%. It is around, what is the literature says, around 17%, but it can say it's around 20%.
So let us move from the MSI to the next one. So that's Dr. Salil. Would you like to do some PET scan for this patient, since the patient has come to a surgical oncologist initially? So would you like to do some other PET scan for this patient?
We don't follow a routine PET scan in all cases of resectable gastric cancer if we are following upfront surgeries. And if we are in proximal gastric cancers, basically the role of PET scan is to prognosticate the disease basically. It's not about staging the disease. Resectable case, you have resected, post-op follow, we can do a PET scan, or as a response to chemotherapy, if you are planning a neoadjuvant setting, you can do a PET scan. But upfront is a staging process, it's not been proven, and we don't do routinely.
So you will straight away take the patient for surgery. So now how?
Thing is, as a staging procedure, next in line in follow-up is a diagnostic lab and a peritoneal liver cytology in almost all of our cases, because we hardly get any T1 cancers, right?
So you are doing a staging laparoscopy with a cytology also.
Cytology, peritoneal liver
Dr.
cytology.
Sahu, what about you?
For any advanced disease, like what is beyond T2 and N+, we should always do a staging laparoscopy and cytology. There are two purposes. One,
No, it should be done. That's what you are doing in your institute. You are doing a staging laparoscopy with cytology.
doing a staging laparoscopy and a peritoneal.
Because in our institute, what I am saying, we are doing a staging laparoscopy for all, but we are not doing the peritoneal cytology for all the patients.
No,
I must say.
it is staging laparoscopy plus peritoneal washing, and it has its own implication. Staging laparoscopy, one is for resectability, to see whether if it is a posterior wall disease, it is adherent to pancreas, you need to see whether it is resectable or not, that's one. The other is obvious metastasis to the peritoneum, that is for staging laparoscopy. And washing, if you are doing, you need to do a very proper
So you are doing washing with 200 ml or 50 ml?
It's 50 to 200 ml. If you are
What
putting
you are doing?
200 ml.
200 ml. You are Dr. Salil?
Actually, we follow 3 quadrants. That is subdiaphragmatic, we give 200 ml, each paracolic 50 ml, and pelvis 100 ml. Like that we follow.
So
follow
Dr.
a protocol
Subhashis,
like
how
that.
many cases you are getting the cytology, in your institute? A surgeon sending you the cytology?
Very few cases.
Very few cases. That's the thing which is happening. Yes, everyone is doing staging laparoscopy, but cytology is something which is very different prospective point of view. Surgeons are thinking that since it's a T2, T3 tumor, when you are shaking the patient, when you are shaking the tumor, there might be an exfoliation from the primary side. The disease might not be there in the peritoneum, and that's the logic why some people are not doing the peritoneal cytology. So you did this one, peritoneal cytology, and my question to the medical oncologist, like, would you like to, suppose if you go a little bit back, would you like to give neoadjuvant chemotherapy for this patient?
So yes, in clinical T2N0, after peritoneal cytology comes negative also. Still clinical T2N0 M0, we can go for neoadjuvant chemotherapy as per FLOT4 study.
So what's the idea about T2N0 giving a neoadjuvant chemotherapy? Like how you are convincing your surgeon or to patients that yes, your neoadjuvant chemotherapy is
yes. So we can go for neoadjuvant perioperatic chemotherapy as per the data we have. But still this patient can be taken up for upfront surgery. Suppose my surgeon is telling I will go for upfront surgery.
See, your neoadjuvant chemotherapy is not going to have an OS benefit, only the
if I
resectability, control of the
between
disease.
the data, FLOT4 versus classic trial, there is not much difference in clinical T2N0. Still we can get a survival benefit with classic trial. But in FLOT4, yes, we have an advantage in clinical T4 and also T3. But in this T2N0, still we can go for upfront surgery. If our surgeon is asking that can we go for upfront surgery, yes, we can go for upfront surgery if peritoneal cytology and DLAB is negative.
Good morning. I am Dr. Sangram here. Sorry for interruption. Actually, I am not agree on that because T2N0 you are telling neoadjuvant chemotherapy based on MAGIC trial, I think. But in MAGIC trial they compared
Float4 trial.
Float4 trial also. Yeah, in Float4 and MAGIC both trial they compared perioperative chemo versus surgery only. There is no data of perioperative chemo surgery versus chemo plus adjuvant. So I don't agree that you should give in T2N0 neoadjuvant chemotherapy.
So that's what I told, that if my surgeon is agreed for upfront surgery,
if
in
it is
clinical
operable,
T2N0 M0, I will agree with that. I'm not saying that must neoadjuvant
if
chemotherapy.
it is operable, we should go ahead with surgery.
Yes.
T3 onwards or node positive, neoadjuvant chemotherapy is a
But
role.
if patient is not very fit for surgery at that moment,
that's
I'll
okay.
go.
That's a different story. So yes, our house agrees that T2N0, yes, upfront it's operable, no peritoneal mets, straight away go for surgery. So
To add, we are discussing a case of distal stomach.
correct.
So whatever the study and trial that is for all, proximal or G junction, we are just extrapolating our data to distal also. But there is no study to say that neoadjuvant is better. We are yet to get it.
Yes, sir. As per the data, we are going for either, we have two options. We are not suggesting completely for neoadjuvant chemotherapy. In clinical T2N0, we can either go for upfront surgery or neoadjuvant chemotherapy. We can still take up the patient if patient is not fit for surgery.
So
In distal stomach, there is one catch as well. The distal stomach may later on very quickly land up to the intestinal obstruction. So maybe sometimes, if we can, patient is also in obstruction as well, showing features of early obstruction, we should go for surgery first, I feel.
Hardly will get a clinical T2N0 with obstruction. It's very rare.
One more point I need to highlight in this setting. T2N0, there are subset of patients which benefit from neoadjuvant therapy. Those group of patients where peritoneal lava cytology is positive. Okay, if you prognosticate those patients, you have to give peritoneal. I am telling about who strictly follow the Japanese guidelines and do a proper D2 gastrectomies. Okay, they follow protocol like they have to do a peritoneal lava cytology, which we follow in our institute. And if it is positive, then we subject the patient for a neoadjuvant chemotherapy and do a peritoneal lava cytology again. If it is negative, then those group of patients, up to 25% patient have a reasonable good survival. Okay, if it is positive again, then there is a role of surgery is doubtful.
So what kind of surgery, Dr. Sahu, what kind of surgery you are going to do for this patient?
Since this is T2, you said it is T2 lesion clinically. There is a asymmetric wall thickening means it is beyond T2. So it's a D2 radical gastrectomy.
So that's a Dutch trial based on which you are saying about. That's a D2 dissection has got a disease-free survival, recurrence-free survival, and trend towards the overall survival. So yes, that's a trend towards a D2 distal radical gastrectomy. So post-op biopsy report has come out to be T1B and N1 disease. So again, my question to a medical oncologist, like what kind of regime, adjuvant CT, whether they want to give, and what kind of regime?
So probably this patient has undergone upfront surgery. Then adjuvant setting will go for classic trial, CAPOX.
So if the patient is been given chemotherapy versus no chemotherapy, forget about the regime. So what kind of difference you are going to make in the patient's life?
Obviously we are going to give a overall survival benefit by adding adjuvant chemotherapy to this patient.
So overall survival benefit based on which trial you are talking about?
Classic trial. Classic trial.
So how much is the benefit?
So almost you can say 5-year survival benefit is there. Overall survival benefit. Almost
chemotherapy versus no chemotherapy.
No chemotherapy.
Dr. Amit?
Talking about adjuvant chemotherapy, role of adjuvant chemotherapy. Role of adjuvant chemotherapy comes as if there is a node positive disease, and second thing, if it is D2 dissection has been done. If personally I feel if it is less than D2, we should go for CTRT instead of.
That's a different story.
Yeah.
Adjuvant chemotherapy benefit benefit to the patient for adjuvant chemotherapy versus no chemotherapy?
I think most of the trials show somewhere around 3 to 5%.
So classic trial,
survival
5-year
benefit.
update is there. Overall survival benefit is there with adjuvant
So
capox.
due to lack of time, we will move to that's the evidence which shows about the MSI testing for routinely for all the investigation. That's the NCCN guideline shows. And that's a plastic trial which shows that PET scan, upfront PET scan cannot replace your staging laparoscopy. So for all the patients, you should do a routine staging laparoscopy and cytology, which cannot be replaced by the PET scan. And for any node positive disease, yes, the adjuvant chemotherapy has been required, and D2 gastrectomy by Dutch trial, which has been required. And this is the same patient where been the D2 distal radical gastrectomy has been done, and that's a biopsy report of T1B and N1 disease. So we move on to the next case, giving a different scenario, and let us see how the things move on. So this case goes to start with 50-year-old male patient with nausea and no vomiting, and no significant past history and family history and no comorbidity. His PSA is 1, and no on clinical examination, no mass felt and no pelvic deposit. So this patient goes to a medical oncologist, initially first to his OPD. Now my question to a medical oncologist, like how you will proceed with this case?
Yes, we'll do first routine blood investigation, upper GI endoscopy, and contrast CT abdomen pelvis.
Okay, then?
In upper GI endoscopy, if we get any growth, then we'll go for biopsy.
So upper GI endoscopy shows proximal, and the growth is there in the proximal and the body of the stomach, and D1 and D2 is passed with little difficulties. And CT scan shows the growth in the lesser curvature and the body, which is reaching up to the subserosa and perigastric node. Biopsy shows signet-ring adenocarcinoma. Anything else you want to do?
So after this, I would like to ask our surgical oncology team for a diagnostic laparoscopy and cytology evaluation. This
So
is
here
already
you
a
are
locally
sending,
advanced disease.
So here you are sending the patient to a surgical oncologist straight away for ruling out a metastasis by doing a staging lap and cytology.
Yes, yes. And along with that also, we'll do the thorax evaluation, CT thorax.
CT thorax you want
Obviously,
to do?
this case I won't go for PET scan, being a signet ring morphology, histology. It won't be giving a high uptake in FDG PET.
So you are not doing a PET CT because
In
of
signet
the
ring morphology,
signet
in
ring
diffuse
morphology?
type, so subcentimetric node also I won't depend on PET scan. The pickup rate is their uptake is very less.
So that's a CT scan film is there, that's a CT scan report is there, and biopsy report. So again my question to, yes, you as you have said, like you will be
Yes,
sending
I will go
this
for
patient for
staging
staging lab. And surgical oncologist did a staging lab and no mets, but peritoneal cytology came positive. Now what next? Dr. Amit?
That is interesting scenario. Actually, when cytology comes positive and laparoscopic no peritoneal metastasis there, then it has been said that the prognosis is a little bit worse than if there is both are negative. So in this case, I will treat it as a NSCT first. Thereafter, I will go for again the peritoneal staging. And if again there is a no peritoneal mets and cytology also comes negative, then I probably the surgeon will like to go for surgery, and thereafter again the adjuvant chemotherapy. If I would basically like to go for NSCT with, it is called as a M1 stage, but still I will go for NSCT followed by repeat laparoscopy.
So you want to give an NSCT. So my question to surgical oncologist, like it's quite a tempting one, I mean operable one, no peritoneal mets, no gross disease is there. Only by routine, what you are sending for the cytology came out to be positive. What you are going to do? How tempting it will be to go ahead with the surgery, or you want to send it for a neoadjuvant chemotherapy?
Definitely, if it is positive, cytology is positive, then the benefit of surgery is nullified in almost 70% of cases according to recent data. So definitely we have to subject this patient for upfront chemotherapy for 3 cycles at least. then subject the patient for, if you are following a protocol of doing a peritoneal lava cytology, if it is positive, then you have to give chemotherapy. Otherwise, there is no point of doing a peritoneal lava cytology. Then you have to repeat it again after chemotherapy. If it is negative, then only you subject the patient for surgery.
So what about the houses, the surgical oncologists who are sitting over here? Dr. Dilip, would you like to? Yeah.
I agree, no, neoadjuvant. There is no
Correct.
confusion in this case.
So all I agree with the neoadjuvant chemotherapy.
Only thing, one of my question to Sri, should I take home the message that in this case, of course, in a signature cell, the uptake of PET CT is less. Should I take the message by going out of this Padmaja hotel that in all signatoring cells T3, I should not offer PET CT scan benefit to the patient?
No, as far as PET CT is concerned, all the trials and studies, whatever is there, the sensitivity for PET in gastric cancer is very, very low. That's one.
Because of the lack of that enzyme which has been present in the moderately and poorly differentiated.
The second point is the perigastric, picking up the perigastric lymph node is very, very low. The third thing is if you have a signature cell morphology, then the uptake is very, very low. The only indication for a PET CT scan in gastric cancer is to rule out any occult metastasis. That's why a staging lab and cytology, peritoneal wasing is a far more better option than a PET CT scan if you do not have any obvious metastasis in a CT scan of the abdomen and NCT scan of the thorax.
So you would like to, so would you like to stamp this patient as a metastatic M1 disease or?
Yes, obviously this is a metastatic disease. If cytology comes positive, I will have one more point. If in 50 years in this patient, suppose patient's PS is very good, then all like what we have discussed, neoadjuvant perioperatic chemotherapy.
So your intent of chemotherapy is?
But if patient coming with PS 3 or 4, for very poor GC, and they are not adhering to our regular follow-up and all, then we may take it as a palliative case.
So your intent of
PS3,
chemotherapy is neoadjuvant or in a palliative setting?
I will take it as a neoadjuvant if patient PS is 1 or 2.
Okay.
And sir, to sir's question, I would say in mucinous in this signature cell histology, in spite of plain FDG PET, what we routinely do FDG PET CT. So PET with CT. That can add some information. Only FDG PET may not be enough.
Sunil sir, may I?
No, it's obvious. Nobody nowadays we are doing only PET. It's always
No,
a PET
my
CT
point.
scan.
My point
Yes,
is one is in mucinous tumor. There is no GLUT4 receptor, very less. So when you will give FDG PET scan, you will do the F18 will not enter to the cell. That's why the sensitivity is very low.
Correct.
So in mucinous or poorly differentiated carcinoma, there is no role of PET scan as such. Faster. Second point, what you told that if that first time peritoneal was is positive, you may intend on your intent may be curative. Then in second time after chemotherapy, if the cytology is positive, then this is purely palliative. There is no rule of it cannot depend on the PS of the patient.
Correct.
Intent will be curative or palliative depending on the disease status, not the patient status. What I think.
Sir,
Correct.
yes, sir.
So
But from beginning, if we have a CS stomach with this cytologic positive with PS3,
No, PS1, PS3, that is only
Correct.
surgeon's choice whether it is resectable or not.
So to
patient
cut
is
short,
operable or not operable.
So to cut short all those
So I
things,
don't
it's
think,
it's a purely in a neoadjuvant setting. It doesn't depend on the PS score, performance score. So
And we have another option, sir.
how many chemotherapy cycle you want to give and then reevaluate it?
Yes,
3,
so-
4?
so as per as I told, if PS1 or 2, I will go for float regimen,
No,
4 cycles.
regime is something
4
different.
cycle.
How many cycles?
Yes,
Float regime?
4
how-
cycle.
4 cycle.
So
and
whatever
then
I
you
will go, sir, that will be as per the evidence. If I am going for ECF, 3 cycle, float, 4 cycle. Float, I will go for 4 cycle, then re-evaluation, cytology positive, then palliative case, as we discussed. Cytology negative, we will go for surgery. Then after that, if we have adequate resource, then we can go for also high-PEC in adjuvant setting. Like
so
post-operative.
4 cycle you will evaluate by staging laparoscopy or by doing a peritoneal cytology?
Peritoneal cytology. Diagnostic lab with peritoneal cytology.
Okay.
So the scenario is like this. Suppose you are doing a staging laparoscopy and peritoneal wasing. If both are positive, it is palliative chemotherapy. If peritoneal metastasis is negative, cytology is positive, you subject the patient for a neoadjuvant chemotherapy. At the end of neoadjuvant chemotherapy post cycle C, you re-evaluate with staging laparoscopy and peritoneal washing. If there is no peritoneal metastasis and cytology is negative, you make it treat the patient with a curative intention.
So, okay, peritoneal cytology came as a negative one, and the patient goes to a surgical oncologist on table. So, in this particular case, so you are going to go ahead with a curative surgery.
We are going to operate with a D2 radical subtotal or total gastrectomy with a curative intention.
So,
though it is cytology positive.
Bursectomy versus non-bursectomy?
So, bursectomy, the trials and studies are showing bursectomy doesn't have
for
any
this patient?
For survival advantage. Just for a negative resection, you need to do a bursectomy.
So, for this patient, for this patient, what you are going to do, Dr. Salil?
What we follow in our institute is, if there is if a tumors are posterior tumor and serosa is involved, we do bursectomy in all cases. If it is an anterior tumor and serosa involved, we don't do. Though bursectomy has not been shown any additional survival advantage, but in serosal tumors, posterior serosal tumors in the lesser sac, we do a bursectomy.
So, what we used to follow is that subserosal disease, wherever it may be, we used to do as bursectomy, and below T3 lesion, we don't do a bursectomy, or maybe a limited bursectomy. So,
bursectomy is only to make it as a
definitely
negative resection. That's all.
It
doesn't have any survival advantage.
So, this final HP report, this is the total gastrectomy which we did, and that's a D2 dissection which we did for this patient. And that's the biopsy report. It came out to be T2N2 disease. 3 out of 35 nodes are coming positive. So, LVI PNI is positive. So, adjuvant treatment. Yes, I think adjuvant treatment will be required. Dr. Lalman Shah is a chairperson, so that's why I'm not asking him any questions. So, but he can give his comment also. You can intervene also, Dr. Lalman Shah. So, this is the final case where I can involve, okay.
I just want to ask, is there any role of HIPEC in that case?
So,
cytology is positive.
So, anyone want to take a HIPEC for this particular patient? Dr. Somsekar is there, sorry. Dr. Somsekar. So, we have got a legend with us, and how the things cannot be, I mean, HIPEC and without Somsekar, so.
Thank you. Anyhow, I have a talk later. Actually, next to pseudomyxoma, mesothelioma ovary, the maximum advancement now has happened in gastric cancer. So, this is one place where prophylactic HIPEC and HIPEC for a disease on the surface has come. Now, current recommendation for gastric cancer is like this. A patient who has PCA less than 9, preferably 7, and who is in good performance status, and who has responded to neoadjuvant chemo, preferably non-signet histology, and you can achieve CC0, are going to have overall survival benefit. So, this is what now we do. We always do a staging laparoscopy. I was hearing the medical oncologist, I love to have a medical oncologist like that who is sending to surgical onco before giving chemo, which is very, very important, because after chemo everything looks normal.
Correct.
It could be a stage M1 and we would have missed an opportunity. So, we always do any T3 lesion or N plus staging laparoscopy. Same time I put a chemo port, so I don't tell the patient that it is a waste visit to OT. Both happens together. And if they have PCI less than 7 to 9, after neoadjuvant we always do CRS HIPEC, and it is 90 minutes, and mitomycin is now the drug of choice.
So, yes, but still now the HIPEC is not into the standard practice. Am I correct, sir? Criteria, but it is not, till now it is not a standard practice. So, that's a final case which we are
Sir, again, excuse me. Here, sir, in the panel. Panel. Sir, we just keep the last part, the adjuvant part in the case 2, which is also very important, a debatable topic.
I'm just running out of 6 minutes is there, that's why I'm just running out of the time.
But we discussed all the investigation and surgical part, and you are skipping the adjuvant part. So here 3 nodes are positive, PNI is positive, pre-treatment evaluation, serosa was involved.
Correct.
So there is a clear debate regarding the role of adjuvant CTRT.
So,
CTRT here.
Adjuvant CTRT.
Yes.
So, but what's your take? I mean,
it should be a
I mean,
debate.
ask the medical oncologist. So, since it's an R0 resection, R0.
So this patient.
I think this is not for us.
So the fire is on the
we left
stage
with
or
5
on
minutes,
the
na?
outside?
We still left with 5 minutes.
Okay.
So this is.
Okay.
Okay. Yeah.
Okay. So, huh. So,
Role of adjuvant chemo is there. Adjuvant chemo radiation. Yes, we won't suggest because of.
Mike. So R0 resection is there and complete report is there.
D2 dissection, D2 lymph node dissection, we can avoid adjuvant chemo. There is no definite benefit.
So based on trial 116, so since it's a D2 dissection has been done, so adjuvant chemoradiation based on only on PNI and LVI, I don't think it is. Yeah, correct.
Yes, the discussion.
So, okay, so we
In this
agree all
particular-
about the adjuvant chemotherapy.
In this particular case, we can avoid adjuvant CTRT in view of preoperative chemotherapy, critics trial, and the D2 lymphadenopathy has been done. If these two steps would not have been followed, then there was a role of CTRT.
Critics.
So if it is a proper D2 lymphadenectomy, it's a R0 resection. I do not believe there is any significant role of adjuvant
Correct.
adjuvant chemotherapy should take care of.
So we move on to the third and final case. We have got only 3 minutes. 67-year-old male patient with gastric outlet obstruction without any comorbidity, and on examination there is a vague mass is there and no pelvic deposit. Again for the workup, like how you will proceed? I mean, yes, with the apart from the upper GI endoscopy and the CT scan, I'm just running because of the time. We need some discussion point of view. The upper GI endoscopy shows distal stomach growth with antrum D1, D2 is not able to pass, and CT scan shows distal stomach with head of the pancreas been involved, and with few perigastric nodes, and the biopsy shows poorly differentiated adenocarcinoma. So this patient is with a medical oncologist. Now, how he wants to proceed? Dr. Amit?
I think this is 67 years old patient already present with the upper gastric outlet obstruction. I will first go to my surgeon. I will send the patient to the surgeon to relieve his gastric outlet obstruction by doing some palliative stomy, or if he wants directly go to the surgery. That's his choice as per patient. So I personally.
Dr. Sanjay, if suppose the patient land up with you with this kind of things, how you will proceed with the patient? So this patient is having a gastric outlet obstruction. He is vomiting. So you will straight away go for a CTRT for the patient. So that means you will be sending to a surgical oncologist. Let him decide and let him do something for this.
So I may involve my medical gastro and put a stent and then can think of chemotherapy.
Yeah,
and then later on evaluate for surgery.
So yes, that's also one of the option is there. So putting a stent and then can go for
since it is not metastatic, put a nasojejunal tube, improve the nutrition, and give new adjuvant chemotherapy and reassess.
So, but what I think is that sending to a surgical oncologist is paramount important because your metastatic workup has not been fulfilled. If you start giving your whatever neoadjuvant chemotherapy or your intent of the treatment will not be defined unless and until a staging has been done. So that's a biopsy report is there. Yeah. So after GJ, suppose you have done some bypass and some sort of treatment may be given by CTRT, or maybe it's a non-metastatic disease and chemotherapy. So I must ask my surgical, how many cases you have gone after this therapy and then you did a curative surgery? How many cases you have done? No, how many cases you got after this neoadjuvant chemoradiation or chemotherapy, and then you get a chance to do a complete surgery in your career? So you did a bypass and then you get a curate. Dr. Saroj?
I differ. I totally agree with Dr. Ghansham sir said. You send across your medical gastroenterology colleague, put a nasojejunal tube, improve the nutrition. If it is non-metastatic with staging lab, then proceed with neoadjuvant chemotherapy and reassess. If it is a superficial infiltration, I like the capsule or something, you save up from the pancreas and do a R0 resection.
So okay, so I do agree also.
Even if the performance status is very good and it is not metastatic, you can also do a gastrohoepals if you are technically sound.
So because of the lack of the time, we just come to the conclusion that staging laparoscopy is a paramount important. It cannot be replaced by the PET scan, and it's a gold standard based on the plastic trial. And PET scan should be done in a locally advanced CA stomach where R0 resection, yes, definitely is a questionable kind of thing in a special situation. And definitely neoadjuvant chemotherapy has been come into role where the T2 or node positive disease is there. Beforehand, a staging laparoscopy and cytology is very important. And for T4B lesion, cytology positive, non-metastatic disease, neoadjuvant chemoradiation or chemo-RT should be an option, and after that re-evaluation should be done. So thank you very much. I must thank all my panelists. I would request my chairperson to put some comment on this one. So thank you very much.
Thank you, Sunil, and thank you all panelists. So on the eve of, since we are discussing gastric cancer, so there is a book published on gastric cancer, the primary editor being Dr. Ashok Baid, and I am one of the co-authors. And on this date, so let us give one book to each of you. Thank you so much. Books?
That's
दे दो संजय सुभाषिष नेक्स्ट सेशन चलो So now we move to the next session is by Dr. Somsekhar on HIPEC. So you moved out of Manipal and joined after. So Dr. Somsekhar moved out of Manipal after so many years, no, and joined Aster Oncology.
Thank you very much. It's pleasure to be here because I always love Bhubaneswar and Cuttack both. People are very lovely, very friendly, excellent food. These are the only patients I don't know who don't do any shopping. And they trust the doctor. Still the doctor-patient, God relation is maintained. Few place that is only here. All other people will take 100 opinion. And when you are in middle path, when it's in medicine, if it is very clear, it's easy. When that in oncology, most of the things are evidence can go this way, that way. But I really love to come. That's why when I was invited, unfortunately, I was in AIMS and Safdarjung. I was doing 2 live CRS HIPEC workshop. I operated from morning 7 o'clock to evening 10 to CRS HIPEX, which was live relayed in AOGD Congress International. But I didn't want to miss opportunity to travel here. I already had a beautiful chai, food, lovely people. So in the given time allotted, I will try to cover, since this is a GI session, I am not covering ovary to be apt with the Congress flow and also the session. GI surgery and HIPEC role only I am covering, because we know that the largest HIPEC in India are done in ovary. In world it is for appendical malignancy and colorectal. Next is ovary, but however, after OV HIPEC 1 trial and now OV HIPEC 2 trial happening in ovary is becoming the number 1, and I have a honor to be the only center outside Europe and US to be part of OV HIPEC 2. I'm invited and I'm part of the trial with Vandriel from Netherlands. So you will see first time in Indian patients data in an international OV HIPEC 2 trial. So I bring warm regards. As Ghanshyam told, I moved to Aster International Institute of Oncology now. It's a 500 hospital across the world, and we have 4 very big cancer hospitals in Bangalore, dedicated hospitals, 4, and all of them have intraoperative radiotherapy. And we have HD Performer 3, the latest HIPEC machine, the only one in India. So I bring warm regards from that. Those of you who want to come down to Bangalore, Dubai or Oman, please join me, and I'm more than happy to show our HIPEC training program and international fellowship. Now remember, all GI diseases with peritoneal metastasis is not peritoneal surface malignancy. It is very, very important to understand. Leaving the ovary apart, all GI cancers are stage 4 to start with. So what is our traditional teaching? Stage 4, no cure, palliation and prolongation of overall survival, quality of life. So remember, all stomach cancers, colorectal cancers, mesothelioma or GI cancers, whatever it may be, gallbladder, pancreas, with peritoneal disease automatically doesn't mean PSM, peritoneal surface malignancy. No. There are a distinct group within that given area where by and large the whole disease stays in the peritoneum. Rarely they have extra peritoneal involvement, and the cause of death and suffering is the peritoneal disease and not deep liver parenchyma, lung or brain or bone mats. So it's very important to understand. Globally, if you look back, ovary contributes the maximum number of cases towards that. The reason is, even when you think you have a organ confined disease in colon or an appendicular malignancy or a gastric, because of the peritoneal current, peristalsis, the current from the pelvis, right, and it goes and stop at the superior coronary ligament, there is a stasis. They will all fail in peritoneal cavity in spite of not being have. That's why Profelochip trial, Colochip trial, Gastrochip, which is now a positive trial, a recent randomized control trial in stomach, where you have T3, N2, prophylactic HIPEC in stomach has shown survival benefit. Just last week from Alvajoro, loco-regionally advanced, non-metastatic, no peritoneal disease stomach cancer, when they added cytorectal surgery, whatever gastrectomy it accounts to, and HIPEC, also surgery and IV chemo alone. Surgery, HIPEC, IV chemo had an overall survival benefit. It is just published last week, you can go back and read. So that is one of the reason, even though we believe it is early, peritoneum looks normal for either laparoscopic camera or human eye, they will recur because there is a peritoneal current. These are the mechanism by which a GI cancer can have the disease. Number one, there will be implants which drop down during surgery manipulation, or they are already on the surface, or the cytology has got a disease already which you are not able to see. Gravity, respiratory movement, bowel peristalsis, that's why they come all along. This is very well stated that if you have an appendicular cancer, if it is at a base more than 2 centimeter, if serosa is involved, 30% of them will fail in peritoneal cavity, forming pseudomyxoma in your follow-up. Remember, even if it is organ confined. So what is this PSM, peritoneal surface malignancy? This is a disease which is confined predominantly to abdomen, involves the peritoneum, both parietal and visceral, and rarely there is a extra abdominal visceral metastasis, and that is not the cause of death. This is a totally different entity, unlike other entity, which you must understand that if you can give a good control. See, traditionally when you give IV chemo, there are 2 limiting factors. What are they? Bone marrow is a limiting factor. There is any cancer cell which can be killed by reaching very high dose of chemo, but you can't do that because the reason is then the bone marrow will also get suppressed and the vital organ GI tract will get destroyed. So there is a right dose that has been found in case of peritoneal surface malignancies and also in IV chemo, beyond which you can't escalate. So with that given dose currently today, what has happened is the peritoneal right concentration of chemo is very low, which means IV chemo what you give is only 1/10 of it goes to peritoneal cavity, not adequate to kill all the cancer cell. So in spite of the disease responding to systemic chemo, tumor marker becoming normal, the moment you stop chemo in 8 to 9 weeks, peritoneal disease comes up. That's why you need a high concentration in the peritoneal cavity, which you can't give IV because then the patient will have so much of toxicity, it is very tough for them to do. So the peritoneal carcinomatosis in the peritoneum GI is classified into 2, primary and secondary. Primary is mesothelioma. There are 3 varieties, you know that. And then we have primary peritoneal carcinomatosis, PPPC. And then you have secondary, which is from gastrointestinal, gastric, appendicular, colorectal, and also now, dermatofibrous the tumors can also come, gallbladder and pancreas, 5% of them come. Then gynecological from ovary and others. So of all the thing, these are the top 5 reasons. Ovary, colorectal and appendicular, stomach, pancreas currently in the world are the largest. You can see that. So even pancreas, diverse rectum. So I keep getting this pancreatic cancer who have responded extremely well to the traditional treatment. Neither they die nor they stop progressing, only the peritoneal cavity is there. So people keep referring them for HIPEC or PIPAC because the medical oncologists are exhausted and they are doing well, only peritoneal disease, and we know that it is a stage 4 disease, there is no role of any surgical, so they keep coming for them. So now my next talk would be based on this statement we brought. We are a group of peritoneal surface malignancy expert. There is a body called as PESOGI, which is Peritoneal Surface International Group. I have the honor to be its council member. It's a permanent invitee until you die. This is a niche club. No election, by invitation. You have to have 100 papers in the field of HIPEC published in international journal. You should have been practicing about 100 HIPEC a year. You should have been an academician and you should have practiced for about 10 years. And the body, individual academic body sees, analyzes you and then they invite you, and once invited for life, you are the council. Sugar Baker, when he started, they never expanded it, they just expanded. Now I have the honor to be part of it. So we brought this particular statement, which I was a co-author, published in EJ. So I will let you know my talk to let you know how we can go up. So we took the 430 centers in the world who do at least 100 HIPEC. I have done more than 1000 HIPEC in Indian patients. I do about 100 to 110 every year. So I have the most recent HD Performer 3 machine with me. So we identified these centers in the world, Australia, UK, US, Europe, and then we analyzed this paper and brought this particular paper to give you a practice. I will let you know. This is a very important slide since the crowd is both medical onco surgeon. Just because you have hammer, everything is not a nail. In surgical oncology, more so in oncology, there is a two different term. What can be done, what should be done. Just because something can be done is not that it should be done. Just because I know I can give immuno, I can operate, I can do HIPEC, I can do, is that to be done? So that is what is the knowledge, ethics, and right approach, a good head on a right shoulder. So this is a very important, I have summarized only pertaining to GI tract. Look at the survival curve of the patients who undergo treatment with peritoneal metastasis. The black one, pseudomyxoma, PMP. It can be from appendix or mucinous tumor ovary. They have got the highest survival if you do CRS HIPEC. So look at them, practically almost 85 to 90% have a 5-year survival. That is the black curve. This is a global 430 center of more than about 1 million patients undergoing CRS HIPEC for GI surgery with CRS HIPEC. Next, can you look back the red one? This is very important, mesothelioma. In that there are two varieties, low PCI, low Ka67, high PCI, low Ka67, high PCI, high Ka67. They don't respond, so I don't send them. I do laparoscopy, biopsy, I look PCI above 15, high Ka67. Even though I can remove all the disease, I don't touch them. My medical oncologist would then give pemetrexate, cisplatin with or without bevacizumab. I may do a PIPAC for them with an intent of palliation but not curative. So second disease which can derive maximum benefit CRS HIPEC is mesothelioma. Remember this, but remember, don't start a mesothelioma treatment without knowing the PCI index and Ki67. That decides they should always be with medical oncologist alone, with you stepping in as a palliative PIPAC and not HIPAC. Then if you follow the blue line, non-pseudomyxoma appendicular carcinomas. You have this goblet cell appendicular carcinoma, signet cell carcinoma. They derive the third best with CRS HIPEC. But look at the difference between the both. It's very important to understand that all the difference. Then you have the green line. Colorectal cancer, PCI below 15. Non-signet histology responding to 4 cycle of neoadjuvant chemo. So they derive the benefit. So about roughly 40% are alive at 5 years. Currently, peritoneal metastasis, colorectal, IV chemo alone, mean median is 14 to 17 months survival. Here you can see almost about 30 to 40% are alive. Then the last comes the stomach. So stomach, what you have to do is non-signet preferably. Signet is not a contraindication. If an young patient signet responding well and limited peritoneal disease at the end of systemic neoadjuvant therapy, don't decline them a CRS HIPEC if you can resect it. But stomach, so less than 7 PCI. This is a very important slide for student to understand. Also medical oncologists to understand the way the benefit in GI happens. So you can look at it. At one spectrum we have almost 90% living at 5 years, and the other spectrum we have 20% living 5 years. CS stomach with peritoneal disease, 20% being alive at 5 is not bad, right? Curative pancreatic disease, stage 1, stage 2. What is the current 5-year survival head pancreas? 15 to 20%. So for a non-metastatic local disease, we do Whipple's, we do BRCA1, BRCA2, we give PARP inhibitor, we'll give FOLFIRINOX. What all for what? 20% 5-year survival. Here we have a stage 4 disease. And remember, many times a good surgery in stomach is not just to achieve 5-year life. To make them eat every day, no vomiting, no bleeding, no misery. There are some field in oncology, Even though OS benefit is not there, for DFS benefit we have to do, because in oncology, adjuvant treatment, curative surgery, OS is the mark, right? OS, you can't say DFS. That's why anastrozole, in-CA breast, adjuvant has no OS benefit, only DFS benefits or tamoxifen. But there are some field in the human body, even though we can't achieve OS, we have to do for DFS. Number one, head and neck cancers, pelvic, colorectal, cervix, and rectal, because here DFS is also important. If they recur rectal cancer, miserable pain, fistula, discharge, and they can't live. With the modern medical oncology advancement, with sequential chemo and metronomic and immunotherapy and target therapy, people live long. You may say, oh, there is no survival benefit, why should I do that? But to achieve a good locoregional control with quality of misery free, like in head and neck and pelvic rectal, you can still operate them. So if those stomach live, 20 lived 5 years, remaining 80 would have a good quality of life, eating without pain and bleeding, and they're fit patient for medical oncologists. So this is a very important slide I want you to understand and spend. I will take one by one in the given time allotted with small amount with my experience. PMP, pseudomyxoma peritonei, is not synonymous with appendicular cancer. PMP is not a disease, it is a syndrome complex where there has to be extracellular mucin. Peritoneal deposits because of appendicular cancer is not PMP. Remember this. Oh, you say appendicular cancer, peritoneal carcinomatosis, so I had a PMP. No. There has to be extracellular mucin, jelly bean appearance. And so you can have an appendicular cancer with PMP, without PMP. So it is not a disease, it's a syndrome complex where there has to be. Because they are extracellular mucin, they are low grade, low Ki67, chemo never acts in them, and they will never respond, they cannot penetrate, and they suffer, and they will never have extra abdominal disease. They will not have liver parenchyma, so they don't die. The best way to die in the hand of medical oncologists is by systemic metastasis. Best way to die is uremia, painless death. Worst way to die is no visceral metastasis, no extra abdominal disease, abdomen is contracting, neither can you eat, you suffer. Home-based TPN, it's worst. Either you go up or stay here. In between, Trishangu is horrible. This is the problem with peritoneal disease. Neither there nor here. That's why local control is very important for them to understand. I run a course for 3 to 4 days only on PMP. So obviously in 20-30 minutes I cannot cover that. When you attend my course, we will do it. Now the next course I am doing in France. You can come there. We can attend. We just did one in Singapore. The recent, all medical onco, surgical, everybody should now follow 2016 Pesoghi classification of pseudomyxoma. I will not bore you, it is very difficult to read. Please read this paper. We brought this paper, I was a part of this consensus, and we published how to manage, when to do appendicectomy and stop, when to do quadricolectomy, when you have to do hemicolectomy, when you have to do peritonectomy, when you have to do HIPEC. You know what is the biggest confusion even among my colleagues, surgical oncologists, they'll call, Sombhai, I did an appendix. They have come, there is appendicular tumor ruptured, abhi kya karna hai? HIPEC, hemicolectomy, should I go back? Take my word, if you have not attended this course, 99% of my colleagues, GI and surgical, don't know when you have an appendicular tumor, when to do hemicolectomy, when to not do it, when to do peritonectomy. Most of the time, appendicular tumor doesn't need hemicolectomy. This is one abused, over-treated surgery. So this is very important. This is the guideline we have brought. So, yeah. So this is the guideline we have brought. I am not going to trouble you. It's impossible. You have to attend my course for you to tell that, but you can read that, what to do. But this is very important. Whenever you see these particular features, can you see this? Small bowel has clumped down. Can you see whole small bowel? If you can see the picture D. In the D, full jelly bean, the whole thing has concentrated down. Whole small bowel has come down, and large volume of intraperitoneal mucin, and then the whole omentum, small intestine. This is called as central displacement of small bowel, or scalloping on the liver, or contour deformity of spleen. You have seen CT scan for various reasons. You never see a spleen. Contour deformity of spleen, centrifugal central compression of the small bowel. Then, if you have a omental disease like this and scalloping of the liver and jelly bean, remember it is a pseudomyxoma. So this is the classification. We have integrated all of them. Those who do peritoneal surface malignancy, HIPEC, I do about 110 HIPEC, 1000 I have done. you must always document PCI index. Laparoscopy is best. Second is MRI with 3 Tesla machine with diffuse weighted imaging. It is called as peritoneal MRI, and your radiologist should give PCI index. I have trained a specific radiologist who will give that. After surgery, you must do what is no macroscopic, microscopic. If you leave any disease more than 2.5 millimeter, then HIPEC will not help, and that patient will not be cured. So it's very important to achieve CC0 or CC1. So PCI, CC score you must put. So this is the conclusion, when to do HIPEC, when not to do HIPEC. What I will do is, I have brought this paper. You can go back and read when to do, but I will summarize all this in one slide. How many of you know there is a surgery called as radical appendicectomy without doing a hemicolectomy? We know radical hysterectomy, radical colectomy, D3 Japanese, D3 CMV colectomy, TME, all radicals, radical cystectomy. How many of you know there is a surgery called as Esincop type 3 radical ovarectomy? Without anything, only ovary radical. Please go back and read that. In my previous talk somewhere else I covered. I will now tell you, this is a beautiful paper by Sugar Baker, who told you should do radical appendicectomy but not knock off the bowel. Doing hemicolectomy, unless the tumor is perforated more than 2 centimeter in the base and margin is positive, has no value. Even then we don't do hemicolectomy because they don't spread by nodes. We just do quadricolectomy. Please keep the ascending colon, hepatic flexure. Let patient have a good, nice nutrition, potassium observation, and good this one. So you can take a shot of this paper. It is taking the appendicular vessel, the lymph node, ileocecal area, a wedge of cecum. This is done by a double L staple technique. So radical appendicectomy, the way it is shown here, is the treatment of choice and not hemicolectomy. Please don't do hemicolectomies for appendicular cancer unless somebody has done lap appendicectomy, margin is positive. Even then, you can go back and do this. You can even keep the IC valve. God has given for a reason, right? If there is a survival benefit, we'll do. That's what. This is where. What can be done, what should be done. Just because I know how to do hemicolectomy doesn't mean I have to do. So this is the surgery which you need to for appendicular. There may be extensive peritoneal mats. Doesn't matter. You can concentrate on peritoneectomy HIPEC, but don't need to be radical and be hard on the bowel when it is not required. All this I spoke, I concluded here. If somebody asks me what you should do, I will ask, perforated, not perforated your tumor, less than 2 centimeter, more than 2 centimeter, in tip, in base, mucin present, not mucin present, peritoneal disease present, not disease. If you answer this question, I almost get every week from all the surgical GI what should we do, because they think, okay, Somshikar is like, HIPEC guy. So they always ask, there is a case, tomorrow I posted for hemicolectomy. I tell them, please don't do that. This is a patient who doesn't need. All patient also doesn't need HIPEC. So this is the conclusion. If you have DPAM, diffuse peritoneal mucinous adenosis, look at what is the recommendation. No hemicolectomy, radical appendicectomy HIPEC. Even if you have PMCA, PMCA is peritoneal mucinous adenocarcinoma. उससे खराब और क्या हो सकता है? Mucin भी है, peritoneal disease भी है, adenocarcinoma भी है. Still see what is to be done? No hemicolectomy. Radical appendicectomy CR. The only condition where you may have to have colectomy is poorly differentiated PMCA or intestinal variety, goblet variety of high grade mucinous signet cell adenocarcinoma. So the message I want to give is, please don't knock off the colon. Understand, within a pseudomyxoma appendicular there are 7 varieties, treatment is different for all of them. This is one of the few conditions where multiple surgery and HIPEC. I have done 5 to 6 HIPEC for pseudomyxoma patient, living over 15 years. This is the only condition in oncology, multiple surgery. There is another condition, low grade liposarcoma retroperitoneum. जितने बार आएगा ऑपरेट करो उतना सर्वाइवल बेनिफिट है. If you have a surgeon who can operate all this, because very complicated, second, third. So this is the only place, like in Besintok, if you see Professor Brendan Moran has done 15 CRS HIPEC for appendicular in one patient living over 30 years. This is the only. It is called as iterative CRS. It is permitted only and only in low-grade appendicular carcinoma with recurrent. They keep living because they don't die, remember. They are non-metastatic, they never go out, their problem is intestinal obstruction and nutrition problem. So this is something which I wanted to say. Every effort should be made to achieve optimal cytoreduction. If you cannot do optimal cytoreduction, there is no survival benefit. I always see that, you know, when I open this, I have 7 fellows who come to train. Across the world, people come to get trained. They will show this, they feel very happy. Sir, देखो अच्छा है, शाम को जल्दी खाना पीना और फिल्म जाएंगे. तो already they will be calling plan, girlfriend, चलो खत्म, inoperable खोलता हूँ मैं, बंद करते 4 बजे. Remember, most of the primary, the enemy for that patient is you, surgeon alone, thinking it is not. The same patient, after 11 hours of me working on that, no peritoneum, parietal peritonectomy out, diaphragm stripped, whole mesentery gone, see the liver, no glycerin capsule also, bichara capsule also gone, liver is standing, not a speck of disease. It looks like better than a normal abdomen God has given. 11 hours, so you can do HIPEC. So when I see such video, I tell my guy, no, you will be little early for tomorrow morning breakfast home, don't worry. So tomorrow hi jayega. So call back home and say that forget me today. So if you spend 11 hours, this is what happens. That is when HIPEC helps. This is very important to understand that a good HIPEC and a bad surgery doesn't go together. I have a special type of table, special type of this one. Patient is immersed in that. It warms you during cytoreduction. It cools you while you are doing HIPEC, and then it makes you normal temperature. You need to have all these setups at available. Special gloves which you can go off, special retractors. Able has supplied me Omni retractor. So you need good retractors for us. And then the right surgery and the right tubing and the right way to do bladder peritonectomy. Only then you have survival benefit. Otherwise you can't have survival. The whole concept of HIPEC is like this. Macroscopic disease is removed, what is seen to nuclear dye by cytoreductive surgery. There is always there is microscopic disease which will come back, which you put chemo into the peritoneal cavity, 10 times you do. So systemic toxicities are not there. If you add heat, penetration is more than 1.5 centimeter. Heat, pressure, and then intraperitoneal chemo and a good surgery and hyperthermia is what actually it does. So all the macroscopic disease is cleared there. Before you start, always clamp the Foley's catheter. I did 2 live operative workshop just in Safdarjung and EMS 2 days back. When I go to scrub, I clamp. So bladder is a pre-peritoneal organ, not retroperitoneal. Ballpoint cautery, 100 spray mode, whole thing is removed. So this technique is called as pouch of Douglasectomy, retrograde hysterectomy, everything removed in parachute. I don't open the peritoneal cavity. I just go back, strip the whole peritoneum like a sack, and then I do that. So you can see that whole pouch where the deposits are there all removed intact outside. This is very important to master this technique. Total parietal peritonectomy, extraperitoneal surgery, pouch of Douglasectomy, retrograde hysterectomy you must do. That is when high dose of chemo into the peritoneal cavity with heat helps, where IV chemo cannot penetrate. But remember, there is already stabilization by medical oncology by giving neoadjuvant. So systemically you are controlled in the nodes in the systemic area. So increased uptake of malignant cell, apoptosis happening, accentuation of the benefit of the chemo. If it acts 1, it becomes double potentiation and enhanced penetration above 39. Hyperthermic benefits already starts coming at 39. It stops at 43 degrees. So you should never cross 43 degrees. Then the chemo is destroyed in heat and bladder perforation bowel is high. So therapeutic window is 41.5 degree. That is one of the reason never try to do HIPEC with a desi machine. This is not adding garam pani, heart lung machine. There are 7 parameters. Number 1, the flow of the fluid should be at least 950 ml to 1 liter per second. How can you ensure that machine? You need to have a pump. Temperature in all the 6 quadrants of the abdomen should always be above 39, never more than 43, preferably 41.5. And you need a pressure of 21 kilopascal. All this should be done. Which machine? So that's why you need to take a US FDA approved machine. If you do it, do rightly, please don't do otherwise. What can be done, what should be done? Take a US FDA approved machine. There are 2 or 3 in company. The most popular one is the HD Performer from Rand, Italy. Very good machine, very fast. So drug, most of the time in GI it is mitomycin, temperature and this. So it's important to avoid hot spots. If you have hot spot, perforation, fistula. If you have cold spots, cancer doesn't kill there and hyperthermia is waste. That's why a dedicated machine of high quality is required. So I have the honor of taking this first machine. It is called as HD Performer 3. The first machine almost in entire Asia is with me. It does a forward flowing and I just change the connector. It does reverse flow also for me. So I use it now. This is the working horse in my institution. Just last week I did about 4 of them, 4 HIPEC. Every day I have a CRS HIPEC because mine is a referral center across the Asia. Almost 2 or 3 sometime I have. So this particular machine, very fast you can achieve, no hot spots, no cold spots, and no human contamination, all a closed system, beautiful. And it comes with a dialysis kit like an equipment, you can use it and throw it one patient, so there are no biohazards for you. So second thing is, this is the technique of total parietal peritonectomy. What we normally do is, I don't open the peritoneal cavity, I just cut the sheath. Once I cut the sheath, then I use a single swab technique, double swab technique, ballpoint cautery, 100 spray mode with saline being spared, and I see all the retroperitoneal structure. I go backside on the vena cava and the aorta and the bladder, right and left diaphragm, all of them together, and then the whole thing actually comes like a sac. Then I do the whole parietal stripping and everything. So you can see that ballpoint cautery, 100 spray mode is extremely useful and very good. So the whole thing, all the structures I see retroperitoneal, and in a sac, it comes like a parachute technique. The whole sac, can you see that? The whole sac has now the disease. Because that is the right way to achieve a optimal cytoreduction. It's a good technique. So we do this technique with ERAS. Average, I discharge the patient on 7th to 9th day. Mortality is less than 1.2% in my institution. Morbidity less than 10%. Sending that patient within 20 days to medical oncologist for first adjuvant is a very important marker. You have to balance this. So then when you open, all the disease would be there. This is a paper which I have published. You can read how my technique of parietal peritonectomy versus this, how it gives a survival benefit for you if you want to do this. So these are some of the techniques which you need to do. There is also, I will take a minute more, okay? I'll take 1 minute more. So this is called as Gleason capsulectomy. Most of the people say, oh, it is frozen, liver is frozen. If you just learn diaphragm stripping, no use. You have to learn stripping the whole Gleason capsule. I don't go at the diaphragm, I go on the liver, then I strip the whole Gleason capsule, and then we remove. And second thing is, there is something called as a peritoneal disease management, Ponta hepaticus. Always open the bridge between segment 3-4 and then the ligament of teres. You need to take that up completely there and then remove it, which is extremely important. Always, people always say porta hepatis recurrence. It is not a porta hepatic recurrence, it is Pontis hepatis between segment 3 and 4. I go down, I open the bridge, and at the left portal vein and the segment 3 duct, there is a disease which needs to be removed, which is extremely important. Hidden areas, you must always look this. Second, people say, when I have a disease like this, inoperable, early dinner. No, late tomorrow morning. You can take a fine tip needle, 100 spray mode, it acts like a laser. Technique 1. Technique 2, ballpoint cautery, 100 spray mode, electrodesiccation. Technique 3, I will show you what we have developed in India, my favorite technique. I take a APC laser, and I take a Varys needle, at the root of mesentery I infiltrate air, and I put my finger, whole mesentery comes out. Like, as a sari, you pente ladki both nicely like that. So you put a air, mesentery lifts up, put your finger, the whole mesentery I can remove. So don't call something inoperable in the abdomen just because you don't know how to do it, it's not inoperable. Make all the effort to do it, or involve a person who can do that. So you can do this, and I have APC laser, I have a plasma jet and a cold knife. These are all the technique, KUSA, which I use because we do 4-5, and they have very less penetration, so there is no injury. Use all these techniques. Second, you must master this pouch of Douglasectomy. I'll tell you how. You can see the whole disease. The whole pouch of Douglas would be kept outside. I always say that you don't remove the disease from the patient. I remove the patient from the disease. Patient को उठा के table से रखना, बाकी सब disease और table के पास में रहेगा. That is what is the technique you have to do. That is when the HIPEC works. This is the standard regime people use with the US FDA approved machine. Systemic chemotherapy in appendicular will not help, but in stomach, colorectal, neoadjuvant, please use it before you go. If it recurs after a HIPEC, that is when we do a PIPAC. I had a honor of being a part of the international program. I am the PI for this program, colorectal and appendix. I had done this. So we had a 236 patient recurrent after HIPEC. When we applied a PIPAC, the survival even then increased beyond 19 months. So this is the paper we are going to publish. I will end in last minute. This is a HIPEC registry of India from all the hospital. People would say in private hospital, Somshekhar may do in one high funda center. Here, AIMS, Tata, all the government international centers are there, 26 centers. This is the registry of India. Over 2016 patients are there. look at the mortality, less than 2% in India. So even in India, when we had a HIPEC register, mortality is less than 2%, morbidity is very low. If you want to do stoma or if you want to do anastomosis, always do anastomosis first. Then you do the HIPEC. This is my paper, which is a prospective, only paper in the history of HIPEC, which showed anastomosis if you do before or after, it doesn't make any difference. This is also published, you can go back. This is the NCCN which has put for mesothelioma, CRS HIPEC as a level 1 evidence. Level 1 evidence for mesothelioma, you can go back and read. So I will conclude in this finally telling this is a Castripec trial which was published recently, which showed that if you use chemo and HIPEC in gastric cancer with 9 PCI, then there is a very high survival benefit, and colorectal cancer up to 14 you can do that. So in conclusion, surgical skill, expertise, understanding the disease of peritoneal, performance state of the patient. Operation successful, patient died. So please don't do that. Look at the patient. Then the setup where you do and what is your skill set. Balance morbidity, mortality and the biology of the disease. None of these are in our hand. Only one thing is there. Surgery performed by aggressive surgical team able to achieve. Don't take a patient for CRS, HIPEC or PIPAC without discussing in MDT with your medical onco, pain, palliative, nursing team being there. They may give a better idea what is the right sequencing for you to do. Keep PIPAC also with HIPAC because it is required for you to do. Right patient should be done in a right way. When everybody agrees, that is when it helps. And the whole team is important. And remember, a fool with a tool is still a fool. So a bad surgery cannot be compensated with very beautiful HIPEC machine. Okay, that is my lovely family, my wife, my daughters who are professional Bharatanatyam dancer. Thank you for inviting me.
My bad throat. Any questions?
Actually, a lot of questions will be there, but difficult to run. Maybe you can meet me over tea, or you can attend our course, or you can attend more sessions. We can ask and discuss and debate.
Super awesome session.
Thank you.
Thank you so much.
Thank you.
Thank you. Thank you, Dr.
Yeah, there is a very long learning curve in HIPEC. When I started it almost 10 years back, the learning curve was 90 cases. Means, see, the golden rule of CRS HIPEC is what? People think it is very complicated. No, mortality is same as normal surgery. Morbidity is same. Patient goes back on 7th day with ERA. First adjuvant chemo is taken within 20 days. Between 2nd, 3rd week, I send my patient back. Now, with all the available technique guidelines, the learning curve has come down to 40. So we have set up a good team in my HIPEC team. All the patient goes through a good nutrition regime, physiotherapy regime. Surgery is done bloodless fast, and there is a specific ERAS regime which we apply. So that's why. But the beauty is, I showed you the Indian HIPEC registry. Lot of cases in India are done in government hospital, very poor nutrition. Even then, across India, in a center who was doing at least about 100 a year, the mortality is around 1, morbidity less than 10%. So if you are doing 2-3 HIPEC, like vacation, I say, ek baar Switzerland gaye, Thailand jaake, aisa nahi hai. If you are doing that regularly, that is the center where you should do, or you have to build up that center. So centers who do 100 HIPEC a year, morbidity, mortality is very minimal. It is like any other surgery. Otherwise, you end up with a problem. In French protocol, 4% is the mortality.
Thank you.
Thank you.
Thank you. Can we take up a few quiz questions? Our quiz master, Dr. Ajay.
So, we have 3 questions and we have cash award for that. These are simple questions. those who will answer first, they will be awarded with cash prize. So you will identify who will raise the hand first. So our first question is, how many lymph nodes are required for optimal surgery in colorectal carcinoma? No. When we will, you have to raise the hand, not answer. So who raised first? So 12 is right. Thank you. So you are surgical oncology colleague? So our second question is, how many adenomas are required to label it as FAP, and how many % will develop cancer if they are not treated? Second part? Right. So ready for third question? Third question. So you have to name this trial. This is the study design. Disease is CS stomach. Patients were randomized to capecitabine with plus cisplatin versus capecitabine plus trastuzumab. So who raised first? Toga trial, right answer. Thank you.
So we proceed towards our next session, role of systemic therapy in advanced hepatocellular carcinoma, recent update. Can I please call Dr. Sushant Kumar Paikre to present his talk?
Hello. Good morning to all, and welcome to all to our temple city that is called Bhubaneswar. So it is nice to have that fourth Indo-Onco here in our state and this city. And this type of event should happen in not only in metro cities, but also Bhubaneswar, like Bhubaneswar, and other tier 2 cities, and so that people know each part of the country, what happening in everywhere. Thank you to organizing team to give me the opportunity to present this topic. And today we'll discuss systemic therapy that about advanced hepatocellular carcinoma. Before going this, we should know the incidence. It is second leading cause of mortality in the worldwide. But in India, it is among 10th most common, but mortality still high. You see, around 34,700 patients are diagnosed, but among that, among these, 33,000 are died. So it is high mortality in our country. This is the BLCC staging, how we manage the hepatocellular carcinoma. Initial stage, if it is very early stage, we know we have to resect it out. But if it is more than 3 or more than 3 centimeter size, or it is portal vein was infiltrated, then we are not able to give the local treatment. So we should go ahead with the systemic therapy. So for advanced or hepatic extrahepatic spread, we have to go with systemic therapy. And in terminal stage and child-pux C, if liver dysfunction is there, then and PS3, then we have to go ahead with the best supportive care. Next, coming to the topic of discussion, that is systemic therapies for management of hepatocellular carcinoma. We know this is the very good slide to show that what are the treatment available for first line treatment for advanced hepatocellular carcinoma. First is sorafenib, then coming to lenvatinib and atezolizumab, bevacizumab. This is the sorafenib. If we going to trial wise, this is a sharp trial in sorafenib. In reflect trial, it is lenvatinib versus sorafenib. And in the IM BREF 150, it is the comparator is the atezolizumab, bevacizumab versus it is sorafenib again. So all the trial they comparing with sorafenib. In sharp trial they compare with placebo. So this is the sharp trial. It was published in 2008, and here they showing there is sorafenib versus placebo. That here they seen that median overall survival 10.7 months versus 7.9 months, which is significantly different. So there is overall survival benefit in across the all region. But if we going to Asia specific, if you going to Asia specific for Asian population, that also they showing median overall survival 6.5 versus 4.2. So we conclude that sorafenib in first line setting unresectable hepatocellular carcinoma, if you are giving, there is a significant overall survival benefit. But sorafenib associated with toxicities, we know sorafenib most commonly associated with mucositis, hand-foot syndrome, hypertension. These are the most common side effects, and also associated with the loss of appetite, and sometimes it is fatigue and gastritis. Then coming to reflect trial, I want to focus here that this trial was published in 2018, and the sharp trial was published in 2018. From the 10 years, we have no choice except sorafenib for first line of treatment. Then the lenvatinib came after 10 years of sorafenib, sorafenib trial. So here they compare with lenvatinib with sorafenib, but here they found the overall survival is 13.6 months versus 12.3 months, which is not significant. But there is a PFS benefit, that is 7.4 versus 3.7 with significant p-value. So, and also there is median time to progression also very much significantly different. And here they also found there is a response rate which is very much significant. It is 24% versus 9.2, which for which we are likely to use lenvatinib in spite of sorafenib. But you may use sorafenib also because there is no overall survival benefit. If you using lenvatinib, then you get rapid response. Most of patients were responded to the sorafenib with no significant difference in overall survival. The lenvatinib also associated with side effect, that is most common is hypertension, diarrhea, or decreased appetite, and also associated with decreased platelet count. This is the real world scenario where they using the total 31 patient, and that BCLC stage C with those are not a viral hepatocellular carcinoma, child pook A, B, C all included, and lenvatinib using 12 mg per day above the 60 kg and 80 mg per day it is less than 60 kg. Here they found PFS, median PFS 7 months, overall response rate 9.35, and disease control rate is 58%. And so if you compare the original trial, and it is matching that it is PFS around 7 to 8 months, and overall response rate is 20% around. This is another trial with real world scenario. They also using PFS benefit irrespective of etiology. That is whether it is viral hepatocellular carcinoma or non-viral hepatocellular carcinoma. in extrahepatic or not extrahepatic, all the groups are compared. They found lenvatinib is effective in all age group, and the forest chart also showing favors in all age group, whether the alpha AFP level is less than 200 or more than 200. In all age groups, they found difference in the lenvatinib is effective. Then coming to that first line, that is whether the immunotherapy is effective or not in advanced hepatocellular carcinoma. This is the IMBRAVE 150, that is atezolizumab, bevacizumab versus sorafenib. That in REFLECT trial, they did not find any overall survival benefit. But in this trial, when they compared with sorafenib, they found overall survival benefit. That in detail, the patients are enrolled as locally advanced metastatic hepatocellular carcinoma, child PUC-A, and ECOG performance status less than equal to 1. This actually, if you ask me, this type of patient we did not found in day-to-day practice in our country, because child PUC-A and ECOG performance 1 with metastatic spread, it is very difficult to find this type of population. But still, they find they enrolled 500 patients enrolled, that is atezolizumab and bevacizumab, that is atezolizumab 1200 mg 3 weekly, and bevacizumab using very high dose, that is 15 mg per kg 3 weekly, and versus sorafenib 400 mg BD. Then the primary endpoint here is overall survival and PFS benefit. The OS here, in the curve, it is around 19.2 months versus 13.4 months with significant p-value with hazard ratio 0.66, and median PFS is 6.9 versus 4.3. So both OS and PFS are very much significant here. Though we are getting the benefit if you using the upfront atezolizumab, that is immunotherapy, and bevacizumab. If you are using, then it have very significant OS difference and PFS difference. But thing is that the patient have to PS1 and child PUC-A. Here the overall response rate is 30%. No doubt it is very much different in the response rate. The another thing is the complete response rate. Complete response rate is very much high. That is 25% have complete response compared to 1% in sorafenib. If you real world scenario, if you discuss, if you are giving sorafenib, very few, like the data, very few patients may achieve complete response rate. But here they were able to achieve 25% of complete response rate. And the disease, that duration of response was also very much high. That is 18.1 versus 14.9 months. So coming to side effect, if you discuss what is the side effect, what is the quality of life in sorafenib, even if it is single agent in oral tablets, it is more toxic than atezolizumab and bevacizumab. Because sorafenib have very significant, that is, they have diarrhea, they have hand-foot syndrome, they have also decreased appetite, all the things associated with sorafenib. And in atezolizumab, it is only the bleeding risk which associated with the atezolizumab compared to sorafenib. And the patient reported quality of life also very good with atezolizumab and bevacizumab. This is the TTD, that is time to discontinuation. Well, how much patient can continue the atezolizumab, bevacizumab and the sorafenib? It is 11.2 months. The patient can take till the 11.2 months till toxicity, that is the time to discontinuation, compared to it is 3.6 months in sorafenib. So quality of life is good, overall survival good, and that progression-free survival also good with atezolizumab, bevacizumab. And coming, that is what are the precautions we have to take before using the immunotherapy and bevacizumab. That like other immunotherapy also, we have to ask whether there is a organ transplant or not, whether there is a autoimmune disease or not, whether there is a immune-mediated pneumonitis, colitis, endocrinopathies are there. And bevacizumab also like whether there is a recent surgery, whether there is any GI perforation, whether there is any bleeding, whether there is proteinuria or not. anything congestive heart failure, we have to see this type of things before using bevacizumab. Another thing also, whether there is any thrombosis or not. So these are the precautions we have to take before using atezolizumab and bevacizumab. Only thing before going to other slide, only thing by this trial, one thing is that everything has benefit here. That overall survival PFS. Only thing here in our resource limited state, it is the economy which prevents us to use this. And another I want to comment here, it was not compared with lenvatinib. Whether it is the immunotherapy is beneficial with that is lenvatinib or not, we don't know. So if patient is affordable, we can use this for advanced hepatocellular carcinoma. Then coming to next, that is there is another trial. It is immunotherapy plus immunotherapy. That is one is durvalumab and tremelimumab. It is using dual immunotherapy, immunocheckpoints we are using versus durvalumab alone and sorafenib. Here the primary endpoint also overall survival, and secondary endpoints are OS non-inferiority. Here again they are taking BLCC stage B or C and child PUC A and ECOG performance status less than equal to 1. And here they enrolled around 1100 of patients. This is the Himalaya trial, where also Ghanshyam sir also were part of this trial, and it is also enrolled in our city also. Few patients enrolled in our city also. And if you are giving the OS, that is, it is around median OS is 16.4 versus 13.8 months, and with significant p-value. Both the trial, the immunotherapy trial, that have significant OS benefit. And the 36-month OS percentage, if you compare, that is 30.7 versus 20.2 months. So here also they have compared with sorafenib, have significant OS benefit. The coming to tumor response and all the things, that is time to response, that is 2.17, and durvalumab 2.09 months, and it is 3.78. So he had the immunocheckpoints has also rapid response compared to sorafenib. This is the treatment related side effect. In my opinion, the side effects are not much difference with sorafenib. In fact, immunotherapy checkpoints, immunocheckpoints are more tolerable than sorafenib, because most of time in our population we are not able to use 800 mg per day. We have to use 400 mg, maybe 600 mg, maybe sometime 200 mg BD also. We have to use sorafenib. It's so much toxic. Coming to the trial, which I emphasize here, is they use lenvatinib, pembrolizumab versus lenvatinib. In this trial, they enrolled 750. The primary endpoint is PFS and OS. Here they did not find any OS benefit, which I emphasized before that this previous immunotherapy trial should compare with lenvatinib, which is now which is maybe significant effect. Here they trial this trial they failed to prove OS benefit if they using lenvatinib pembrolizumab versus lenvatinib. So even some factors are favors lenvatinib pembrolizumab, some factor also lenvatinib alone. So then another topic is here, whether the etiology based treatment is possible, or whether patient is viral infected or not infected, the etiology factor is the hepatitis virus or not, then the treatment can be changed. This question was asked, and for this ESMO has some guideline. They enrolled non-viral advanced SCC and atezolizumab plus bevacizumab, lenvatinib or sorafenib in 36 centers in 4 countries. Here their primary endpoint also overall survival. So here they found lenvatinib alone is very much significant in that is in non-viral hepatocellular carcinoma, which are associated with alcoholic hepatitis or fatty liver. This type of patient are benefited with lenvatinib alone than atezio bevacizumab. Here both the overall survival and progression-free survival are more significant in lenvatinib alone group than compared to atezolizumab bevacizumab group. So these are the summary of the first line treatment, front line treatment, phase 3 trial, lenvatinib, so sorafenib, atezolizumab, bevacizumab, all the trial are summarized here. Then coming to second line systemic therapy, if you are using, this is the slide, it's a very good slide to summarize how to use the second line. If you are using atezolizumab, bevacizumab and it failed, you can go ahead with cabozantinib or ramucirumab if the alpha fetoprotein more than 400, or you can, if you are not using atezolizumab, bevacizumab immunotherapy previously, you can use nivolumab, pembrolizumab or nivo plus EP. If you are using sorafenib or lenvatinib. Or you can use, after lenvatinib if failed, you can use cabozantinib. Cabozantinib may be the second, in second line therapy may be the treatment of choice if you are using immunotherapy and lenvatinib. So these are the another thing, the regorafenib, cabozantinib, ramucirumab. These are all the anti-VEGF inhibitors. So, so if you going to, I already discussed cabozantinib, we can use second line due to time constraint. So we cannot discuss details, but I can to focus the cabozantinib. If you have percentage progress, cabozantinib have some help if you are not using anything. So cabozantinib plus placebo, cabozantinib have a very significant overall survival benefit and PFS benefit. It is 10.2 versus 8. So already this is the data, the resource trial. This is regorafenib and placebo. One thing I want inform to you, regorafenib can be have beneficial effect if you are using first line is sorafenib. But if you are using lenvatinib or atezo bevacizumab, regorafenib may not work. So this is the highlight. And for ramucirumab, it is the alpha fetoprotein. If more than 400, we can use. So this is the summary of the second line therapy. What are things to be used or not to use? The regorafenib, ramucirumab, cabozantinib. Only thing regorafenib can be used if you are using the sorafenib in first line. This is the guideline that atezolizumab, bevacizumab is the category 1 recommendation for first line. In our state, if the patient is affordable, we can use atezolizumab, bevacizumab if patient have child-poor class A. And other things are sorafenib, lenvatinib in the other recommended regimen, and we can use second line in the ramucirumab, cabozantinib. Thank you.
Thank you, Sushant. Thank you, Sun, for the sponsored session. So now we move to a panel discussion, advanced colorectal cancer. So moderated by Dr. Chinmay Pani. Dr. Amit Kumar will be joining virtually. Tushar, to nahi. Amit Kumar join kar dekho tume. Amit Kumar join kar dekho.
Yes, sir. Joined.
Yeah, okay. Sumit Goyal is also joining virtually. Then we have physically Prashant Parida, Sudham Sadangi, Sangram Kesri Panda, Dr. Aparna Dhar, and Tushar Mahapatra. Chair, जाओ ऊपर चले जाओ. Sumit join करते हैं.
I'm there, sir. Good morning, sir. I'm there, sir.
Yeah, thank you, Sumit. Thank you. Good morning.
Yes. Good morning, sir.
Good morning to you all, and respected chairperson, my honored delegates, and it's a proud privilege given me the platform by Dr. Bishwas to discuss about the panel discussion regarding metastatic colorectal cancer. And my learned esteemed panelists are there with me, to whom I am going to ask questions very quickly. So due to the time constraint, I requested everybody to speak very focused point, because otherwise we'll have difficulties in doing this. So I'm so sorry. Can we last? Okay. So here you go. We all know. Okay. Still it is not working. Okay, sorry. So my panelist, Dr. Amit Kumar is there online, and Dr. Goyal sir is there, Prashant is here, and Dr. Sudham is here, and Sangram is here, Dr. Dhar is here, and Dr. Tushar is here. So you all know that in the global data that the colorectal cancer incidences are increasing, and the number is quite high, and so also the number is quite high in India too. So my first, if you see the colorectal cancer, metastatic colorectal cancer, it may be an oligometastatic disease, or it's maybe a disseminated metastatic disease, and almost the data shows that 15% are the oligometastatic disease, and almost 85% are non-resectable at clinical presentation, and out of which the never resectable are in the range of 70 to 90%, and 10% are potentially resectable. Is the same thing that you got in the clinical practice, or you beg to differ, or you have any difference in opinion? Anybody can say. Prashant, you are in a very high volume center, you can say. So my question is that, are you seeing the resectable metastatic patient in 15% of out of all metastatic colorectal cancer, or your number is less or more? Okay. Sure. Sure. So for evaluation, do you routinely practice PET-CT in a metastatic colorectal cancer? To Dr. Amit, who is in online? Do you routinely practice?
No, sir. So for colorectal, it is mostly the CT, thorax, abdomen, and is being done. Only in rare situations where we are thinking it to be a potentially resectable disease, in that case, we are going for the PET scan in those group of patients to rule out if there is a metastasis also. Otherwise,
yes.
So for routine practice, it's only a contrast CT.
Okay. So Dr. Tushar, can you elaborate in which condition you provoke or you call to the medical oncologist to go for the PET-CT?
Chinmay, so far as NCCN guideline is concerned, so far as oncologists are concerned, the role of PET-CT in carcinoma rectum and carcinoma colon ends before it starts. It's like, so if you go into few points, that is CT and MR are adequate in evaluation, and whenever there is an equivocal finding or doubt, you can go for PET-CT for confirmation. And universal indication, wherever in any type of cancer where there is creatinine is increased, or chronic renal failure patient, so you can go for PET-CT because you cannot give contrast in the CT scan or MRI. the most common indication or the classical indication is when there is a potentially the plan of metastatectomy.
So oligometastatic disease that you are telling.
Potentially resectable disease. So
thank
you can go for PET-CT to rule out any other site of metastasis.
Correct. Okay. Correct. Almost it is clear. Routinely not indicated. In oligometastatic disease definitely. There is some indecisive condition where the contrast was an issue or the intermediate lesion, or in the monitoring per se, and if there is a little bit confusion, and there is another condition when there is asymptomatic rise in CA, and you are not getting any lesion in that condition, PET may help you to get an early.
Chinmay, for the house, the summary or the single liner is when anatomy is not distorted. That means you have not intervened. Surgery is not done, radiation is not done, no chemotherapy is not done. It's always the anatomic modality, either CT or MR. But when anatomy is deformed, it is the PET-CT. That is the summary of the investigation.
So there are many influencers that changes the treatment plan. One is patient, another is molecular characteristics, then there's tumor characteristics, then the patient preferences, then finance and cost. So many are the determinant variable that will change the treatment outcome, and out of which the anatomical location, the right and left, change the mindset after 2016 or maybe 2017, and there is a lot of data coming that what is effective, what is not effective in the both right and left, etc. and etc. But the most important thing is that what the progress we got, it is due to the availability of the biomarker that actually changed the treatment paradigm of the patient. So and initially we got in difficulty because probably the block what you send from the pathology and for the evaluation for not doing the biopsy in the metastatic setting, and we got a call from the molecular oncologist lab that the fixation of the tissue is not proper. So my question to Dr. Dhar, so can you elaborate how to make the block properly so that we won't get a call like that in order to increase the sensitivity of the test? Yes, madam. Okay. So thank you. So it is basically a neutral buffered saline, and this is the retention time, and you are telling maybe 10% tumor is perfectly fine. Okay. So fantastic. The other questions is that, sorry. So other question to madam, because we need to understand and how, when and what to profile, because there are armamentarium of lot of molecular biomarkers that has been developed, and my questions to my medical oncologist that routinely the molecular testing should be done. So are you doing in 100%?
No. If you will ask me for my opinion in my personal or in my clinical practice, Though there are some patient support program from the company side where I was able to do it almost 60 to 80% of cases. But nowadays they have withdrawn, so almost 50% of cases I am able to do, especially at least individually, KRAS, NRAS, BRAF. So these are the tests, and though MSI or MMR should be done in all cases of colorectal carcinoma from the diagnosis, whatever the stage may be, but most of the time I am not able to do that also. So also
Thank you.
for to new, I have started to do in the first line whenever it is possible. So if you will ask me, it is less than 50%.
Okay. So, Sumit sir, are you there? So, are
Yes,
you
I'm
doing
there. I'm
the...
there,
Yes,
Dr.
sir.
Chinmay.
Yes, sir. Are you doing the repeat biopsy from the metastatic site or the primary site sample you are sending?
It depends. If it is an oligometastatic disease, definitely we are trying to prove the metastatic site also whether the disease is there or not. But if the tissue is not there, it does not matter from where we are sending. Till a year back, we were sending for all the patients, but now we had a thesis program, so that's why we were able to send. But now, rightly said, there are a lot of constraints. We are not able to send in all the patients. But yes, we are trying to send in as many as patients who are affordable, approximately 60%, 50%, the same range.
Okay. So my another question is that, madam, you are a very proponent of the liquid biopsy. So can liquid biopsy replace the tissue when it is not there for doing the testing? So my quick question to Sumit sir. So are you doing sequential or you do NGS upfront?
No, we are not doing NGS upfront because the value, to my understanding, is very limited that we get from NGS. What we are doing is we are doing MMR, MSI, either part of the PCR test that is incorporated in KRAS, NRAS, BRAF, and HER2 we are doing by ISC.
So, Dr. Amit, what do you prefer in MSI, either do in ISC or in do the PCR testing?
No, ISC is initially what I am considering in my practice. The first line sending ISC for all the things, and rest the BRAF and all rest with the PCR based. Otherwise, MSI, ISC, and HER2 ISC, which I is practicing.
So if the first line mutation, sorry, if the first line you have started chemotherapy and then the disease recur after a duration of 2 years, so do you do the repeat testing? Madam, are you advising to go for the repeat testing? If the sample is good and first NGS has been done, and so are you advising to go for any, so I mean to say any change of mutation pattern seen when you are seeing a not second prime in the metastatic in the second line? Agree. Okay. So, Mr. Do you agree? If you have done the NGS in the first line, are you provoked to do the NGS in the second line when it is metastatic?
See, NGS, actually, I did not hear what the madam said because the panel is, the voice is not there. We are not able to hear that. But our understanding is what we are doing is, suppose I have run out of the treatment options. I may be tempted to do it at the end if I have done it earlier, just to see whether something is there or not. The second indication that we are doing is, suppose we are re-challenging with EGFR inhibitors. Then to see the NeoRAS variants, maybe we are doing at that point of time. That we are doing on liquid biopsy also sometimes.
Okay. Okay, sir. So I'm not going to ask in this regard more. And these are the the recommendation by the 4 marker has been advised by the ESMO. So you are all well read and well. So okay. So I'll not ask about the HER2 testing now because of the lack of time. Kindly make the screen enlarged. Okay. So the outcome has already been improved and it is going on improving, and there are a lot of new recommendations coming to move forward. So let us go to to surgeon. So what is your basic, because you know as the lines increases, the progression-free survival decreases and the response rate also decreases. So most important thing in discussion in a MDT, that whether it is a upfront resectable or not. So you just tell me what are the oligometastatic disease where you like to operate first, and what is your policy in your MDT and how you prefer? Dr. Sudham.
Upfront operable, you are selling, sir?
Yeah. So initial resection when you want to do, or what are the indication of the oligometastatic disease when you want to go for surgery? It is only liver only disease, or it is liver, maybe lung, or any peritoneal disease, because Dr. Somsekhar told that the peritoneal disease, some segment you can do surgery too.
If a limited metastatic disease, then obviously we will go for first chemotherapy and followed by surgery.
Okay, so I mean to say, in what condition in the MDT you will tell the oncologist that the surgery can be done, what is in the liver part, what is in the lung part, what is in the peritoneal part, does it have any survival advantage of doing the surgery or doing the local therapy to this?
Yes, if it is limited metastatic disease to the liver, we can go up to metastatectomy up to minimum 3 liver metastatectomy we can go. But before that, we should proceed for chemotherapy for the survival benefit. And even after lung metastasis is there, we can go for lung metastatectomy after chemotherapy.
Okay. Regarding peritoneal, what is your option, Dr. Sangram?
Yeah. So first we have to see how much the tumor burden in a metastasis. Means in only one organ like liver, or multiple outside abdomen or inside abdomen. Second is we have to see what is the, can we achieve the R0 resection. Primary site is resectable or not, that is first important. So, if primary site is resectable, then only metastatic has a role. Otherwise, it has no role. Second thing, we have to see if metastatectomy and primary resection can be done simultaneously or staged procedure. Okay. That is another point. So first we have to give neoadjuvant chemotherapy, then go ahead with surgery like either simultaneously primary with metastatectomy or staged operation, then completion of the chemotherapy. So, but there is no consensus regarding that whether you will go ahead with simultaneous surgery or staged procedures. It is totally surgeons dependent and surgeon's decision, purely surgeon's decision depending on the local extent of the disease and resectability, whether we will achieve R0 resection or not.
So the ESMO guideline says if it is a clearly resectable, go for resectable. If it is a borderline or the resectable is in a little bit of confusion, then go for the neoadjuvant chemotherapy. Yeah. And before doing neoadjuvant chemotherapy, you plan for the molecular profile, then you give chemotherapy. Regarding the poor performance status group in older age, Dr. Prashant, so are you always tend to give the doublet or singlet is better in an older age? If singlet, then what is that? Number one. And number two question, if it is younger, then are you intensifying, giving the triplet therapy. So what is your opinion on that?
So doublet versus triplet.
No. In older, when the performance status is low, are you giving single agent chemotherapy along with targeted therapy? If
yes. So those who are frail patients or elderly with some comorbidities, even it has been seen few trials, single agent with biologics or as a monotherapy. It is
Very
also have similar benefit with
so
doublet
you have
also.
answered the questions. Single agent chemotherapy along with biologics like bevacizumab can be tried. There is data from the PANDA study that the 5-4-uracil along with panitumumab versus the modified FOLFIRINOX, and in the wild type group you can give panitumumab and cetuximab in the group of more than 70 or 75. And does young age is a poor prognostic factor, Dr. Amit? If you see a patient of less than 40 colorectal cancer with metastasis, are you tending to provoke the patient that will respond poor? Are you intensify the therapy in subgroup of patients?
Yeah, surely if the patient performance status is good and a young age, I'm going for the triplet regime along with the addition of the targeted therapies in those group of patients. So,
okay. So per se, Sumit sir, are you telling something? So per se, the patient, those who are younger, they behave very poorly in spite of the adequate treatment, and intensifications of chemotherapy may not improve the survival of the patient. And another important question I like to, can you last one? So definitely when the oligometastasis is there, then definitely there is an improvement of the overall survival. So are you telling, Dr. Prashant, are you telling that the cure can be achieved in oligometastatic colorectal cancer? If that can be achieved, that is in the liver limited disease or in the peritoneal disease or in the lung disease or in all of the three?
Yes, if with resectable metastatic disease and we resect, the outcome is better. Even some of the trials and meta-analysis shown that those are resectable will resect. The 5-year survival is almost 30% around.
Fantastic.
And if you will resect.
Correct. So correctly you have narrated.
Yes.
So patient resectable and surgery have resected, the outcome is better. Resectable, not resected, the outcome is poorer, and if it is unresectable, then it is less interest. It is not only for the disease of the liver, but also in the peritoneum, though there is lack of randomized control trial, but we provoke to think because our surgeons are very aggressive, they can able to do the high pec, and so also that has been extrapolated to the pulmonary metastatic too, to go for the surgery after giving the neoadjuvant chemotherapy in that setting. So till what extent, if the lung and liver both are involved, if lung, liver and peritoneum both are involved, till what extent you can go for doing surgery? So 1 disease, 2 disease, 3 disease, 4 disease. So what is your...
Actually, surgery has role in oligomets, not in extensive disease. First of all, if in liver only, yes, there is a survival is up to 30% over survival. Lung, livers, also you can go ahead. If lung has 2 to 3 deposits, it can be resectable.
Perfect.
And in peritoneal disease, of course, there is no standardized randomized control trial, but still there are Icarus study and 2-3 studies are there who found around PCI less than 15, it is a very good prognosis and good survival. More than 15, we should not go ahead. And recently, PRODUCE 7 trial, French trial also came. In that, they compared CRS versus CRS plus HIPEC also. In that, they found CRS is benefit, overall survival benefit, but adding HIPEC, there is no extra benefit of survival. Also, it is increasing the complications. So, PCI less than 15 in a peritoneal disease only, and that the limitation is that disease should not go beyond abdomen. Then only peritoneal disease, we can go ahead with CRS. Plus minus HIPEC.
Perfect. So, my question to Dr. Sumit sir. Sir, left-sided RAS wild type. Left-sided RAS wild type, what is your preference and what is your chemotherapy backbone, oxaliplatin versus irinotecan, and the targeted therapy of choice, panitumumab vis-a-vis cetuximab?
So first thing is left-sided tumor. RAS wild type, pan-RAS wild type, BRAF not mutant. My choice definitely is to add EGFR inhibitors. So backbone, it will depend upon the 2 things. One is the age and the toxicity comorbidities of the patient, the likelihood of neuropathy that patient is likely to have, and the renal function test.
So patient is fit.
fit, I will add Folfox with the panitumumab, but there is no such thing. We can add either panitumumab or cetuximab. But the FDA approval, I think, is with Folfox, and first line is with panitumumab. But we can use either of them.
Okay.
And if there is contact
Sir,
indication or something.
Sir, my question is that Folfox, Latron, Folfiri, vis-a-vis Folfiri, Latron, Folfox, the result almost equal. So
That's
how you
the same.
optimize to give Folfox or the Folfiri? So that's my question, sir.
I will give Folfox first.
Okay. Okay.
The results are the same both ways. Anyway, whatever you do, they are
So perfect. There is, I think, no doubt about it. Everybody agrees that you have to give either Folfox or the. Regarding the two targeted agent, panitumumab versus cetuximab, how you choose and opt, Dr. Amit?
Yeah. So it's mostly what in our practice is mostly using cetuximab in this group of patients. There's no hard data to not to give panitumab, so it's just counseling the patient and we can choose either.
Okay. So my next question is that in the KRAS mutant and in the right side and VRAF mutant. So what is your options of therapy? Either right side, number one, number two, mutant BRAF, and number three is KRAS mutant. What is your option, Dr. Prashant?
So if KRAS mutant, the biologics will be always bevacizumab along with bevacizumab, either doublet or a triplet. So it depends upon who is someone younger patient with potentially resectability. Then I will prefer a triplet, where because if you will give triplet, the response rate will be higher.
Perfect.
And so it has been seen that the response rate is correlated with the resection rate also.
Perfect. So basically, you prefer to give the triplet and along with bevacizumab because it has a low response rate, so that it can give the conversion rate will be high to go for the surgery, and overall survival data not came. That is yet to mature. This is by the Cairo 5 study, and so also the VRAS mutant cases. So in the MSI high, are you routinely practiced to give pembrolizumab to the patient, or still you are giving chemotherapy? Because the penetrations of the pembrolizumab into this in the range of 3% because it's a cost factor. So what are actually doing in the MSI positive group?
So the data regarding MSI high subgroup, especially those who are unresectable or potentially resectable, we have options of using IO like pembrolizumab or Nivo plus EP.
Yes.
But the data is promising, so we have to wait for the mature data, the OS data. So that is a very good option with good quality of life, because if we start with some IO agents, quality of life will be better in comparison to the triplet plus biologics.
So I think this is the algorithm. The first line, if it is clearly resectable, go for surgery, and if it's not resectable, then do the MMR status. If the MSI is high, go for MNO by the keynote trial. If it is stable, then it is fit for the chemotherapy. Then left and right, what we have already discussed, and the BRAF already well discussed. I think I am stopping this because of lack of time, and I'm not going to the maintenance. Do you believe in maintenance? Are you giving maintenance just one half line? Okay.
Yes.
Okay. So then second line you have to opt Latron and choose the alternative drugs, and I think I have covered some topic, and okay, thank you very much.
So Dr. Aparna, what is your take on doing a regular ctDNA patient,
because lack of time, I could not
patient
ask
who has
you.
progressed on anti-EGFR? So what is your take on that?
So in adjuvant and vis-a-vis in metastatic setting. That's my.
From a treatment monitoring perspective, in a metastatic, yes. Adjuvant too, I think we have very good data that's come up that does show the benefit of ctDNA. However, then if you are doing ctDNA, it has to be done from the correct lab. It comes down, because it's very sensitive, right? So when your patient has gone through adjuvant chemotherapy or has even progressed, or you're doing it in a metastatic setting, it's extremely difficult calling on these mutations. The sensitivity has to be very high. So whoever's your service provider, I know everybody cannot go to a garden or to a foundation, it's expensive, but even your domestic labs, please ensure that the depth of coverage is a minimum of 15,000x. Then you know you're getting your treatment monitoring done right on ctDNA. Anything less than that should not be
my question is now on metastatic setting, are you still convincing or using the ctDNA data? In adjuvant, there are enough data. In metastatic?
Absolutely, because if you suddenly see progression, you have, so in metastatic setting or any, when we're just treating patients in general, you know, as just before the resistance comes in and the patient starts responding, if you can see that slight spike, you get to change chemotherapy, so it might not change line of treatment. It's easier, I wouldn't say easier, but it's a little less difficult versus, you know, when the patient, the tumor is fully resistant. So while yes, this, it's very clear cut in adjuvant and metastatic we're still getting there, but I've always seen physicians using it more in a metastatic setting, and we have seen it to be very, very beneficial, to be honest.
Thank you. Thank you.
So another question. So normally KRAS, NRAS, BRAF, HER2/neu, MSI have been done on baseline. Patient exposed to oxali, irinotecan, bevacizumab, cetuximab. Still good GS. So what is the role of doing a CGP or NGS? So what is your take? So are you going to pick up something which can be a driver so that the patient can get some benefit of that treatment?
So upfront CGP, I think for me, if a patient can afford upfront, the reason I would prefer it is because while it will not tell you the driver from a therapeutic implication, it will actually help you understand what is the tumor biology. Is this an aggressive tumor? Something like a KEAP1 mutation will tell you your patient will not respond to chemotherapy or immunotherapy or just any therapy in general.
Yes.
So a lot of these genes are actually indications that are telling you what's happening in the tumor, what is the tumor thinking. So to understand your next line of treatment, I prefer CGP, but I know it's very expensive, but it does help me understand the biology of the tumor, which in turn helps our...
It's not more expensive than a human life, definitely.
Absolutely, that I say, but you see, then it happens that, oh, the molecular person only wants CGP, so I put that caveat.
So people spend so much on cetuximab, panitumab. So it is half the cost of one cycle.
One course of therapy is half that cost.
If you can afford immuno, you can do this for sure.
Thank you so much, Chinmay.
Thank you, sir.
Thank you so much, Sumit and Amit joined virtually. So we now move to one of the keynotes sessions by Dr. Sabyasachi Parida. And so he'll talk on oncoplastic techniques in breast cancer surgery from his own institute, KIMS.
Very good morning, and thank you for giving me the opportunity to present my work. So as you can see, it's a vast topic. So what I'll be doing is I'll be touching upon that part that is relevant to practice and that I can do justice with rather than the entire gamut of it. And so you'll have to bear with me when I skip certain parts just by mentioning them. So these are my, it's not working, okay. These are my disclosures, so it's always teamwork. And this is how we'll still proceed. So it shall be part of science, the art, and some of those that I can consider as innovations. So coming to the science of it, now as you can see, breast cancer is the most common site for cancer worldwide. Incidence is increasing, faster increase in countries like ours, and India ranks with China and USA among the top 3. And more and more younger patients, although you still have more patients aged above 50 as a bulk of it, but more and more younger patients are getting breast cancer at a faster rate. So breast cancer survival is increasing because death rates are coming down. So, and that leads to is that it is the most prevalent cancer today. What it implies is that more and more younger women are suffering from breast cancer, survival is improving, and hence the importance of quality of life of the survivor is becoming more and more important. So I want you to remember this. This is a background on which we shall discuss. So more of science coming from radical to modified radical to breast conservation. So that's all data which proved it. So is this enough? Probably not. That's because when you are not replacing the lumpectomy cavity with adequate tissue, then this is what might occur. If you want to avoid these things, therein comes a role of breast oncoplasty. So what are we doing in breast oncoplasty? We are trying to remove the cancer with adequate margins of normal tissue, while at the same time making the patient look as good or better than she looks now. So you remove the ideal volume, avoid breast deformity, and reduce the indications for mastectomy, make BCS safer oncologically and better cosmetically. So coming to basics of it, incisions, these are what you consider in case of other skin lesions, but in the breast the incisions can be different. So if you know these incisions for small volume disease, these will be adequate. So bat wing, hemi-bat wing, semilunar, and these all incisions. So this is how it was classified by Krishna Claw et al. When they proposed it initially, that when you have less than 20% of the volume excised, level 1 techniques suffice, 20 to 50%, then advanced techniques come into play. So if we try to understand roughly what it means you have two different types of techniques. One is volume displacement, where you are displacing the breast itself, remodeling the breast to make up for the deficit. As a corollary of that, you are reducing the breast volume. So there are techniques at the bottom part which means reduction mammoplasty. So that is one part. The other part is where you are replacing the volume deficit with other flaps which are coming from near the breast. So that is another part. So coming to displacement techniques. So this is J-plasty. Roughly, this is a cartoon I made just so that you can understand. There's a left breast lesion that is excised. So you move the breast medially so that is what you get at the end. So it is a smaller breast, the nipple areola rises up a bit. So this is a matrix rotation technique. Again, you can remove good volume and then do that. You can also do dual planing. That means you can move the breast parenchyma separately from the skin if required. So that is another technique. This is a Grissotti flap. This is in fact the first flap that we had done in 2015, and these are the results that we got in that case. Matrix rotation, this is a filled streamer, but I'm showing it just to show you the technique. So those are the results. Reduction mammoplasty, I'll mention in passing, is based on an understanding of the blood supply of the breast. So it may be a supramedical, medial pedicle, inferior pedicle, and the like. And this is what I mean by that. So I do not do much of this, so I'll not be talking about this more. The replacement techniques are my forte, perforated flaps are my forte, free flaps come into place when required. Now when you're talking about perforated flaps, it may be based on vessels which may be a LICAP, which may be an anterior intercostal perforator, medial intercostal perforator, lateral thoracic artery perforator, or even a TDAP. So free flaps, of course, you can do. So coming to perforator flaps, a semilunar flap is not based on any particular perforator, but nevertheless, it can be used for small defects laterally. You can use a lateral intercostal artery perforator flap also for defects. So those are the results. Thoracoepigastric flap is an uncommonly used flap which can be used in cases where there is an inferior deficit. For this patient, this is there. That's a deficit. The ACAP pedicle is shown to you just for demonstration. So that is the result. LTAP flap is my favorite flap. Here I'm using it for a superior defect. That is the flap. And those are the early results. So adjunct techniques to BCS, I shall mention in passing. Lipomodeling is very important when you have contour defects. NAC graft, or you can have nipple sharing that can be done for reconstruction. Sentinel lymph node biopsy by blue dye or by using ICG, these can be done. There is a lymphatic tract and all. So axial reverse mapping is used. Blue dye is not very effective. ICG is effective when you want to avoid damaging the axial lymphatics while doing an axillary dissection. So sometimes you may see this. This is very rare. This is part what I had captured once. So going ahead, lymphovenous anastomosis may be done at the time of surgery if you want to avoid lymphedema. And in those cases who have lymphedema, you may go for lymph node transfer. So moving ahead, specimen mammography comes into the picture when you have a patient with DCIS. This patient has got segmental DCIS with small foci of carcinoma. So how we go about doing it is this patient also had involvement of the subareolar plexus as per an MRI. So resection volume in this will include that part along with the areola. So that is a defect, and that is a specimen mammogram which has been compared with the patient mammogram, and that you can see has led to proper excision. So again, the flap is there, ICG has been used, that is the flap, and there are the results. Wire-guided clip localization comes into picture when post-NECT the lesion is no longer palpable. You have put a clip in the lesion. This is pre-NECT, post-NECT, that is the clip only visible. So you localize the clip with the help of a wire. So you can see the clip over there. That is under ultrasound. That is the wire with the introducer needle. Needle being placed inside. I shall go forward. So that is the wire in place, and you can see it is within 3 mm of the clip. So this is how we proceed. That is a specimen, and you do a specimen mammogram to ensure that you have excised adequate volume of tissue around that clip. So that is a reconstruction for the patient, and that is how it is. So coming to the innovation part of it, there are some innovations in my practice that I've done that are not commonly reported, are not in world literature. So the MICAP flap for upper inner quarter lesions is something, this is a reoperative case where we had DCIS in the upper supromedial part, and we had to reoperate. So that is how we locate the medial intercostal artery perforator. So that is a flap. That is a pedicle of the anterior intercostal arteries, again not required in this case. You are seeing the MICAP perforator there, and that is after reconstruction. So LTAP flap for central breast lesions is something that I am doing routinely nowadays, and this is the case. This is how you localize the LTAP pedicle with the help of a Doppler. That is there. So other pedicles have been marked out. I will not be showing them because of want of time. Okay, so that is the patient where you, that is sentinel lymph node biopsy, lumpectomy, that is the vessel. There you can see the vessel pulsating. That is the lateral thoracic artery. That is the flap ready. And this I'll show as a video if possible. So reconstruction is completed. Then in extreme oncoplasty is where you have larger lesions, or you have multifocal lesions, or you have multicentric lesions. Even in those cases, carefully selected cases, you may go in for oncoplasty. So this is a case of large volume replacement where you have a patient who has got multifocal disease, post-NSAT, persistent, some lesions are close to skin and hence require skin excision also. So that is a resection specimen, more than half a kg, that means almost half of the breast has been removed. So that is a flap. It encroaches on the territory of the LICAP and LD. That is a pedicle. Deeptheliation in progress. The pedicle, that is a large volume replacement. That is on table. These are on table aesthetics. They are even better right now, but I don't have the images right now for that. And LD for thoracodorsal artery perforator for total breast reconstruction. This is a patient who was a reoperative case who had extensive DCIS. So we had to reoperate. That is the flap planning. This is the TDAP perforator localization. So that is post skin and nipple sparing mastectomy. The specimen showing you the DCIS part covered in that. That is the flap planning, and that is on table. Once we have divided all the attachments, then we see whether the perforator is still intact or not. That is there. So that is a pedicle insert. There's another flap involved over here that I'm not mentioning, but that is on-table aesthetics. That is early. The patient has some got a hematoma that's been drained. There's an operative video I'll show you. So before you start, you always define the breast footprint so that you know what is the volume deficit, where your incisions are to be placed. We have marked out all the perforators which are there so that if required, they may be utilized. It has been speeded up, so it will be done within 5 minutes. This patient has a central breast lesion, so we are marking it out so that we can excise that as part of the lumpectomy. Methylene blue is what I use commonly. Certain cases I do use ICG. You incise the superior part for the sentinel lymph node dissection. The biopsy is done while taking care of the pedicle, the sentinel lymph node packet, and in this case it was mentioned as positive. This is actually, I think, 2 years old case. So in that case, we have gone ahead with the axillary dissection also. So that is lumpectomy in progress. So I'm palpating as I'm excising. That is the specimen. The dye marks out the orientation, but we shall put for the sutures also for orientation. That is a cavity shape that we send routinely, including the deeper part. 5 valves we are sending. So because we are going ahead with an axillary dissection in this case, we have to be very careful with preservation of the pedicle. Now that is a bit tricky, and it is not advisable if you have extracapsular extension, extensive nodal burden, it's not advisable. You will have to rely on other accessory pedicles or another flap like a TDAP flap. So that should be at the back of your mind also, and you should be ready with that also. So that is how we are dissecting out. In this case, they had told that the medial wall appears suspicious, although on histopathology it was all clear. So we revised it then and there. That is the pedicle after the axillary dissection. Intercostobrachial nerve is also visible. Cavity marker clips are placed before we start the reconstruction proper. So the lower border of the flap is incised. As you can see, I have revised the lower border to account for the increased volume loss that has taken place. So that is why we put the inferior margin, define the inferior margin later on. So I have encroached on the territory of the LICAP over there, lateral intercostal artery perforator. So therein you can see the LICAP vessel. There are 2 or 3 vessels. One of them will be larger. Here we are sacrificing that vessel because we have a bigger vessel to support that flap. But if required, a smaller flap volume can be very well supported by a LICAP also, but you have to be very careful with the dissection. Most cases I prefer an LTAP if it is there, because it is more robust and gives me more volume. So an access tunnel is created in front of the pectoralis major into the lumpectomy cavity. We are putting it in so that we can determine where to place the neoareola. That needs to be defined. The volume distribution of the tissue has to be assessed, and then you define where you want to have the areola on the flap. So that is what is being done in order to study. Here, if possible, you should have a table which is at least 80 to 90 degree head up, so that you can see how it appears when the patient will be upright. The trick here, when we insert the flap, is also to put it in a way that it doesn't remain in the upper parts of the breast. It has to fall down with the natural fall of the breast once the patient is upright. So that is de-epithelialization. You can do it in different ways. The cheapest way is, of course, a blade. You can use the scissors, but again, that makes it blunt. No, it's continuing. So de-epithelialization has been completed. The neoareola is ready. Now the flap is ready for insert. The trick I told you earlier is that how you place this flap, how you distribute the volume that is there is very important. Otherwise, you can have good volume inside, but the contour will not come. So you have to understand, where do I put the anchoring stitches? Excess anchoring stitches are not required, just 1 or 2 will suffice. You should have the, once you have put them, have the patient upright and check whether it is adequate, proper placement is there or not. So I'm bringing the neoareola to the level of the surrounding skin. Subcutaneous followed by subcuticular stitches. So that is how we come to closer. I shall end the video at that, although I do have time. Okay, so take home messages. These are the most important part, and I want you to listen to them very carefully. You have to understand the disease biology. Without understanding the disease biology, you must not treat a patient of breast cancer. Must not. You understand the disease biology, it is what it dictates to you that you do to the patient. You understand the biology, you plan out, if I am going for neoadjuvant, what kind of neoadjuvant? If it is showing you that it is not responding, should I change the regimen? Don't overlook ever overlook the disease biology. This is the most important point. Understand the patient. If a patient does not want breast conservation, after you have explained everything properly, again and again in multiple sessions, do not give that patient breast conservation. That patient will not be happy. If a patient wants it, you give it. You have to explain what you have, what you can offer to the best. Let the patient choose. Study the breast characteristics. Different shapes demand different approach. Breast composition is important because if in a glandular breast, you can move the breast around much. You can play around rather, to put it literally. But in a fatty breast, you have to put in volume from additional places. That means you have taken a flap rather than move about the breast. Breast measurements are important, especially when you are going for reductions. So you have to learn a wide range of techniques so that you have backup. If one technique does not work or you need additional tissue in a particular case, you should be knowing how to take care of that. So individualize and apply the simplest one applicable to the patient. That will give you a happy patient. So thank you. Thank you very much for the opportunity. I hope I have made justice to what has been done. Thank you.
Thank you so much. So now you move to a talk by Dr. Latendu Maharana. So he'll be talking on a role of bevacizumab in non-squamous metastatic NSCLC.
Very good morning to all of you. I'll be talking about the role of bevacizumab in non-squamous, non-small cell lung cancer. Next slide, please. This one. So, this discussion will base it on we'll discuss it in two headings. First, we'll discuss about the role of bevacizumab in metastatic non-small cell lung cancer, which do not have a activating mutation. And second, we will discuss about those cases who have an activating EGFR mutation. So, first the rationale, why bevacizumab is thought to be having a role in metastatic non-small cell lung cancer. As we know, angiogenesis is an essential process of tumorigenesis, proliferation and metastasis. And many of the environmental factors and genes that are involved with tumorigenesis may increase the vascular endothelial growth factor, which ultimately will bind to the vascular endothelial growth factor receptor, and that ultimately will lead to survival, proliferation and migration of the endothelial cells and leading to angiogenesis. And targeting tumor angiogenesis is thought to be like a therapeutic goal in many of the cancers, and is postulated to improve the survival in these patients. And in particularly in lung cancer, it is thought to be very important because like those lung cancer patients who are having microvessel density high or vascular endothelial growth factor level high, those have been seen to having poor prognosis in comparison to the patients who are having low vascular endothelial growth factor level or low microvessel density. So this ECOG 4599 trial, it tried to test this postulate, hypothesis that whether bevacizumab is having any role along with chemotherapy in this setting. What it did, it randomized non-squamous non-small cell lung cancer patients, stage 3B and stage 4 to 2 arms. One arm received paclitaxel and carboplatin 6 cycles, and the other arm received paclicarba along with bevacizumab. And what it found, like the primary goal, overall survival was significantly higher in comparison to the paclitaxel carboplatin arm. And not just the overall survival, PFS as well as overall response were also found to be significantly better in bevacizumab arm, bevacizumab containing arm in comparison to the paclitaxel carboplatin only arm. So, and and in this trial, those patients who are young, less than 65 years, with good performance status, PS ECOG performance status 0, found to derive maximum benefit out of bevacizumab addition to the chemotherapy backbone. So this is another real-world retrospective cohort study taking patients from the SERC database, and it also compared whether it also tried to find out whether addition of bevacizumab had any survival benefit in comparison to the chemotherapy only. So it also found that addition of bevacizumab resulted in longer overall survival in comparison to chemotherapy paclitaxel carboplatin arm only. And this holds true for both the young patients as well as the elder patient, more than 75 years or less than 75 years. Both cohorts are actually deriving benefit out of addition of the bevacizumab. So that's how bevacizumab became came into the first line treatment along with chemotherapy in metastatic non-small cell lung cancer who did not have a activating mutation. And as we know, the Paramount study, it found that after chemotherapy induction, maintenance pemetrexed had PFS benefit in those persons who have responded to induction doublet with pemetrexed and carboplatin. Likewise, after bevacizumab came into picture in the first line induction along with chemotherapy, some studies tried to find out whether continuing bevacizumab beyond induction had any survival benefit to the patients. This is one study, ECOG 5508. It in this patients were patient given paclitaxel and carboplatin along with bevacizumab for 4-cycle induction chemotherapy, and then patients were randomized to either bevacizumab only maintenance or pemetrexed only maintenance or bevacizumab plus pemetrexed maintenance. And it found that in terms of overall survival, there was no survival difference, significant survival difference, whether patient received combination maintenance or a single agent maintenance with bevacizumab only or pemetrexed only. But there were significant difference in terms of progression-free survival in combination maintenance arm. Likewise, another study, COMPASS trial, it also tried to find out this same answer to the same question, but here chemotherapy backbone was PEM carbo instead of paclicarbo. So patient received PEM carbo plus bevacizumab 4-cycle, then maintenance PEM bev or bevacizumab only. And this study also found that there was no overall survival difference with maintenance PEM bevacizumab arm in comparison to bevacizumab only. So no significant overall difference of bev plus chemotherapy maintenance. So if we are planning to add bevacizumab in the maintenance after induction chemotherapy, in that situation, we know that there is no overall survival benefit, only PFS benefit is there. So we have to take into take into account other factors like potential cost and whether patient is tolerating it or not, or patient preference. All these things has to be taken into account when planning a combined bevacizumab plus chemotherapy maintenance after induction bevacizumab along with chemotherapy. So, and this point break study, it tried to find out like which chemotherapy backbone is better, whether it is pemetrexed carboplatin or paclitaxel carboplatin. So, it randomized patient to bevacizumab plus PEM carbo followed by PEM bev maintenance, or pacli carbo plus bevacizumab followed by bevacizumab only maintenance. What it found that in terms of PFS, in maintenance population, that is those patients who received at least one cycle of maintenance, in those population, the PFS was significantly better in PEM carbo along with bevacizumab arm in comparison to the pacli carbo arm. But again, there was no overall survival difference between these two arms. So, and if you see this forest plot, we can see there is no significant difference between the response rate and usually those young patients and those patients who are young patients are deriving maximum benefit. Young and ECOG performance status 0 patients are deriving maximum benefit if at all in the PEM carbo arm in comparison to pacli carbo arm. So, while deciding on chemotherapy backbone, there is no difference in overall survival between pacli carbo or PEM carbo along with bevacizumab if you are planning. So, likewise, the bevacizumab came into the category 1 indication in the first line setting in non-small cell lung cancer patient who did not have a activating driver mutation. But in the present scenario of immuno-oncology, this Keynote 189 trial, what it found that addition of pembrolizumab with chemotherapy backbone is it had survival benefit irrespective of the PD-L1 status. So, after this Keynote 189 trial, pembrolizumab along with chemotherapy backbone became the preferred first line regimen irrespective of the PD-L1 status. So now the question is, does bevacizumab has any benefit in the present era of immuno-oncology? This question was answered in this IM Power 150 trial, and it tried to test the chemotherapy backbone along with bevacizumab along with immuno-oncology drug atezolizumab. So it randomized patients into 3 arms. One arm received PEM carbo, pacli carbo along with bevacizumab. One arm received pacli carbo along with atezolizumab, and third arm received both atezolizumab and bevacizumab along with chemotherapy backbone pacli carbo. What it found that ABCP arm, that is atezolizumab and bevacizumab along with chemotherapy arm, had both PFS and overall survival benefit, which are statistically significant in comparison to bevacizumab and pacli carbo arm. So therefore, at present scenario, at present era, so it is the category 1 indication for those metastatic non-small cell lung cancer patients who do not have activating driver mutation. So NCCN also incorporates this regimen as a category 1 indication, that is bevacizumab along with atezolizumab along with chemotherapy backbone of paclitaxel and carboplatin irrespective of the PD-L1 status. If PD-L1 is more than 50%, again there is an option of IO only and IO plus IO, but irrespective of the PD-L1 status, we can give paclitaxel carboplatin chemotherapy backbone along with bevacizumab and your atezolizumab immuno-oncology drug in first line. So coming to our next question, does bevacizumab has any role to play in those non-small cell lung cancer which are having activating driver mutation, activating EGFR mutation? So this NEJ026 trial, it tried to answer this question, and it randomized patients into 2 arms. One arm received, this patient randomized patients with activating EGFR mutation, that is exon 19 deletion and exon 21 mutation, that is L580, 8588R mutation, and it randomized patient to 2 arms, that is one arm received allotinib only and other arm received allotinib plus bevacizumab. What it found that there was significant difference in terms of progression-free survival in the bevacizumab arm, that is addition of bevacizumab had significant PFS benefit in comparison to the alertinib arm only. But when overall survival is compared, there was no significant difference in overall survival in comparison to the alertinib arm only if we are adding bevacizumab. So, and if we do a subtype analysis in the overall survival statistics, we can see whatever benefit patient is deriving in terms of overall survival is actually more pronounced in those patients who are having exon 21L858R mutation. That you can see the hazard ratio is also better, and your p-value is also, both the p-value is not significant, but p-value is tends to be significant in those patients who are having exon 21L858R mutation in comparison to exon 19 deletion. So if fatal patient is having any role to, if fatal bevacizumab is having any role to play, it is more pronounced in exon 21 mutation rather than exon 19 mutation. So in another study, Beverly trial, it also tried to answer the same question, and in this study also there was significant PFS benefit in bevacizumab, in adding bevacizumab to alertinib arm in comparison to alertinib only arm, but there was no overall survival benefit in the bevacizumab arm. And but this is a very interesting forest plot, and we can see those patients who are never smokers, who are actually current smokers. Current smokers, they derive the maximum benefit of adding bevacizumab to the first line anti-EGFR TKI, that is alertinib. And these are all other studies which try to answer the same question, like addition of bevacizumab to the first line, to the first generation alertinib in this population, in this patients with activating EGFR mutation. And most of these studies found PFS benefit, but no OS benefit. So at present era, so is there any role of adding bevacizumab to alertinib? So we can say when third generation anti-EGFR agents like osimertinib is the treatment of choice, and it is associated with far better survival in comparison to first generation TKIs with bevacizumab. So if your patient is eligible for osimertinib, patient is patient can afford, patient is eligible for osimertinib, then probably osimertinib is the way to go. But those patients who are not eligible for osimertinib, whatever reason it may be for, those patients we can add bevacizumab to first generation TKIs in order to derive maximum benefit for those patients. But is there any role of adding bevacizumab to the third generation TKIs like osimertinib? These questions will be answered in this trial. These are ongoing trials of addition of bevacizumab to osimertinib. This question, whether bevacizumab is having any benefit of adding to osimertinib, these trials will answer these questions. So coming to the last part of my discussion, that is it is a very difficult subset of patients to treat. That is those patients which are having exon 20 insertion, and we know they don't do well with EGFR TKIs, and usually we prefer to treat them with chemotherapy. We prefer, and NCCN also tells that these patients should be treated like those which are not having any activating EGFR mutation. So this is a Chinese trial that tried to find whether bevacizumab is having any benefit in those. There is median survival benefit of adding bevacizumab to the chemotherapy backbone in this subset of patients in this trial. And therefore, NCCN tells to treat them like those patients who are not having EGFR activating mutation, that is chemotherapy along with bevacizumab plus minus I. So to concluding, metastatic non-small cell lung cancer without any driver mutation, yes, there is benefit with bevacizumab induction and maintenance, and we know that the few of the studies have found overall survival benefit, and in terms of maintenance is concerned, overall survival benefit could not be found, but if patient is fit, performance status is good, and patient is young, we can add bevacizumab to derive the maximum benefit out of it. And in terms of EGFR mutation, positive non-small cell lung cancer is concerned, adding bevacizumab, it helps obviously in exon 20 mutation and exon 21 mutation also. It can derive some, a patient can derive some survival benefit if patient is not a candidate for third generation TKIs like osimertinib. Thank you.
So thank you, Lord Andu. So can I make a statement and you have to say yes or no? So bevacizumab as an anti-VEGF lost its path in the lung cancer treatment. Probably got a new partner in EGFR space. Is that right?
Yes, sir. Like after the invent of the osimertinib, which is having overall survival of almost up to 36, 37 months. So, with the addition of bevacizumab to the first generation TKIs, we could not achieve that that degree of overall survival, that degree of benefit, we could not achieve. So therefore, bevacizumab actually lost its parts in the way when better TKIs with better CNS penetrance came into picture. But addition to the third generation TKI, that question has to be answered yet.
Thank you. Thanks so much. So now we move to the last talk of fourth iOS. So after this talk, so we'll have the award ceremony followed by, for any organization, any conference is valedictory. So there is already a lunch being served. Please don't go away without having lunch on a Sunday. And after that, who all are interested for the radiotherapy workshop, they can go to Apollo, or we can have a live display of the sessions here, so people can stay back also. Otherwise, people can go straight away to Apollo. So now we move to the last session by Dr. Sajida Begum. So she will be joining us virtually on behalf of Aspira Nutrition, and she will be talking on nutritional preconditioning. So you talk so much about keto diet, we so much talk about intermittent diet. So she is going to take over from now. So Dr. Sajida.
Good afternoon, everyone. Am I audible? Is my screen visible?
You can start.
Good afternoon, everyone. I am Dr. Sajida Begum. I am presenting Aspira Onco Nutrition. Here I am the Medical Affairs Manager. So I would like to thank you everyone for giving me this wonderful opportunity to present my work today. Next slide, please. Can you please present my slide from there? I'm not able to change my slides from here.
Is she facing problem or what?
Yes, I'm actually facing issue to change these slides.
So till the time is it ready? Okay.
Okay, I'm able to change now. Okay, so we were talking about how nutrition plays an important role in the quality of cancer patients. how will the slides would be changing? I'm not able to change the slides. Is somebody there to change the slides? Yeah. Okay, so how this is important? So since cancer patients experience unintentional weight loss leading to the diagnosis of cancer, so emerging evidences have shown that around 20 to 25% of deaths, which are during the cancer treatment, before the cancer treatment, and after the cancer treatment, this can be prevented with the intervention of proper nutrition to the patients, which can definitely improve the overall quality of life and well-being. Also, several research papers have suggested that loss of lean body mass, like sarcopenia in patients in cancer, is an independent risk factor of poorer outcomes. So as the cause of the death in the developed world, cancer is one disease which is surpassed by cardiovascular disease. So globally, number of people with cancer is projected to double by 2030. Currently, more than 1 in 3 people will develop cancer in their living. Next slide, please. Our request to change the slide, please. Hello. So in the year 2020, there has been estimation of new cancer cases, which is around 1.92 million cases, and around 6.09 lakhs cancer deaths has to occur. I would request to come on slide number 4. Hello. Thank you so much. Thank you so much for sharing this screen. So we have seen that in the year 2020, and there is expected that there would be a number of new cases, which would be around 1.92 million cases, and 6.09 lakhs cancer death has been estimated. So cancer is a major public health problem worldwide, and this is the second leading cause of death in the US. Please change the slide. Next slide, please. So the number of new cases in 2020, we have seen that the breast cancer has been the maximum one, which is around 11.7%, followed by lung cancer, colorectal cancer, prostate cancer, and NMSC, and other cancers like stomach, liver, cervix, uteri cancers. So number of deaths in 2022, which includes also both the sexes in all ages. So maximum number of deaths which is seen in lung cancer cases, which is around 18% cases, which is followed by colorectal, liver and stomach cancer, followed by breast, esophagus and pancreas, and prostate and other cancers. Next slide, please. So since how cancer and nutrition is interrelated. Now, metabolic and the physiological alterations, they affect the nutritional status and changes the nutrition needs even before anti-cancer therapy. Anorexia, early satiety, taste and smell changes, and GIT disturbances. This leads to inadequate nutrient intake in the patients and thus causing malnutrition. Now, this malnutrition influences the metabolism, the pharmacokinetics, and healing dynamics. Highest prevalence of malnutrition is seen with 30 to 50% of hospitalized cancer patients. Next slide, please. Next slide, please. Okay. Now we will talk about the metabolic reprogramming in cancer cells compared to the normal cells. Now, some of the most striking changes of the tumor cells, the bioenergetics, this includes the elevation of glycolysis, increase in glutaminolytic flux, then upregulation of the amino acid synthesis and the lipid metabolism, then enhancement of the mitochondrial biogenesis, induction of the pentose phosphate pathway, and the macromolecule biosynthesis. So compared to the normal cells, the cancer cells, they prefer using glycolysis even in normoxing condition as well. So this phenomenon is known as the Warburg effect. Now in normal cells, this glycolysis is prioritized only when oxygen supply is limited. In contrast, the cancer cells preferentially use glycolysis even in the abundance of oxygen. So this is why the tumor glycolysis is often called aerobic glycolysis or the Warburg effect, to distinguish from the normal anaerobic glycolysis as compared with the normal cells or the healthy cells, which we say in layman language. Next slide, please. Now, why is nutrition during cancer treatment is important? Now, nutritional deficiencies, this often contribute to fatigue and reduce the quality of life of the cancer patients during the treatment. Now, this adequate nutritional intake is important for maintaining energy levels, muscle mass, and a healthy weight during and after treatment. Now, in turn, this will improve the treatment tolerance, improve the quality of life of the patients, and reduce the risk of adverse effects in cancer patients. Hence, proper nutrition during the treatment supports the immune system, which may lower the risk of infection, help healing, and recover faster. Next slide, please. Now, how is malnutrition associated cancer? As per the previous slides, which we have already talked about, now I'll talk in a very simple, terminologies, like what basically malnutrition we mean. So this is a very common problem which we see among the patients with cancer affecting up, which is about 85% of the cancer patients. Now, in severe cases, this malnutrition can progress to cachexia, which means a loss of lean body mass, loss of skeletal mass, muscle wasting, and which impairs the immune system, the physical and the mental function is also compromised. So cancer cachexia is also associated with poor response to therapy, increase the susceptibility to treatment-related adverse events, as well as it results in poor outcome. The treatment outcome is compromised, and hence the quality of life is also compromised. Now, early intervention with nutritional supplementation has been shown to halt the malnutrition, and this will improve the outcome of the cancer patients. Next slide, please. Now, how malnutrition impacts the cancer patient? First of all, it is related with immunocompetence, which leads to decreased cell-mediated immunity, depressed this T-cell proliferation, NK cell cytotoxicity, and macrophage cytotoxicity, inability to tolerate the antineoplastic treatments. Toxicities are more severe here. It results in treatment delays and hence leading to higher cost of treatment. We have also seen post-operative complications like we can take example like wound infection, there would be delayed healing, hence compromising the quality of life of the patients and increase the treatment cost. Next slide, please. Now, what do we mean by nutrition preconditioning? So it has the potential to prevent short-term toxicities, improving the therapeutic efficacy and reducing the late life effects. Nutritional strategies have been shown to reduce the endogenous DNA damage levels and to boost the maintenance and resilience mechanism. So this protects the body from exogenous damages like chemotherapy, radiotherapy, and protective survival response prior to DNA damaging treatments. Nutritional preconditioning might prevent these toxicities in normal tissues. So probably to a lesser extent or not at all in the tumor, thereby alleviating the short and long-term side effects and the burden which is experienced by the cancer patients. Next slide, please. Next slide, please. So over the years, nutritional preconditioning has been used in cancer disease management. We have seen this in 4 stages like dietary restrictions or caloric restrictions, where the reduced calories by 20 to 40%. We have seen about in ketogenic diet, which is a high fat, low carbohydrate diet, around 70 to 80%, it has been seen that it has improved the condition of the cancer disease patient management. And short-term fasting, only water is given for a range of days here, and fasting mimicking diet, which is a low-calorie diet for a period of 5 to 6 days schedule, and which includes the plant-based and low-protein diet. Next slide, please. So we will talk about ketogenic diet as this plays a very important role during the chemotherapy and the radiotherapy treatments. So we have seen several studies. So this is one of the research paper from where I have taken this. So this study includes a very small number of patients, or when started with a larger cohort, experienced dropout during the study. So most trials has included the safety and feasibility of ketogenic diet. Consensus, this seems to be feasible and safe in patients with different types of cancer. So this combined results suggested that a ketogenic diet for a maximum of 5 to 6 weeks, consisting of a ratio of fat to other macronutrients of less than 4.1%, 4:1, is most promising as a feasible intervention. Next slide, please. So this is the metabolic pathway of ketogenic diet. So when glucose is scarce, the body seems to form of energy for the cells. So the liver then produces the ketones and the fatty acids, which provide to normal cells, but they do not benefit the cancer cells. They benefit only the normal cells. So this is due to the cancer cells become heavily dependent on ATP coming from the less efficient process of glycolysis. So these diets, they slow the cancer by inhibiting insulin and downstream the intracellular signaling pathways such as phosphoinositide 3 kinase or protein kinase B or mammalian target of rapamycin. So ketogenic diets also amplify the adenosine monophosphate activated protein kinase, which inhibits the aerobic glycolysis and suppresses the tumor proliferation, invasion, and migration. So we have seen that mouse models of metastatic cancer shows that exogenous ketones themselves have direct cytotoxic effect on tumor viability. So 5-beta hydroxybutyrate can modify the chromatin by binding to and thereby inhibiting the histone deacetylase, ultimately repressing transcription and curbing the cancer cell proliferation. Next slide, please. So when the availability of nutrients is reduced, cancer cells cannot easily adapt, in contrast to normal cells. So which may render them more vulnerable to damaging agents, a condition termed differential stress sensitization. So tumor cells that have difficulties in adapting to nutritional preconditioning conditions and normal cells that go into defense mode and can already result in tumor shrinkage by the nutritional preconditioning regimen. Next slide, please. So we will talk about how amino acids, this plays an important role and they starve the cancer cells to death. So this pathway talks about commonly import of amino acids from the bloodstream. Amino acids is deprived and micropinocytosis this contribute to internal amino acid pool. So these are used for energy production, macromolecular biosynthesis like the proteins, nucleic acids, lipids, and glutathione, and methylation processes. So this tight balance between the amino acid uptake, biosynthesis, and catabolism is controlled by mammalian target of rapamycin complex 1 and general control non-depressible 2. This MPORC1 facilitates amino acid metabolism in response to amino acid availability. So this includes a global shutdown of the translation, bringing cells into quiescence and in order to able to survive the nutrient shortage. So if these stress conditions persist, apoptosis is induced. So to fulfill the enhanced demand for amino acids, cancer cells often upregulate amino acid homeostasis and metabolism. So here in the picture, you can see these are marked with red, and this involves mutations in commonly mutated cancer genes, but also these genes directly implicated within the pathways of amino acid homeostasis and metabolism. Next slide, please. So what is the goal of this nutritional therapy? So we prevent or resolve the nutritional deficiencies, preserve the lean body mass of the cancer patients, help patients to better tolerate treatment, minimize nutrition-related side effects and complications, maintain strength and their energy, protect immune function and decrease the rush of infection, aid in recovery and healing, hence maximizing the quality of life of the cancer patients. Next slide, please. Please enter. Next slide. Now, what the studies suggest? Malnutrition is not only about not being able to get nutrition, but it is also about taking the right nutrition. For example, if a person is getting food and this is diabetes, cancer, or all these diabetes, cancer, or all diseases crop up because there is no sufficient amount of nutrition. So nutritional therapy cannot cure cancer, but can bring the optimal outcome of the drugs, which has been used to treat cancer. Different types of cancer needs different nutritional interventions, like nutritional preconditioning, which means the body is gearing up chemotherapy. Next slide, please. Now, most of the cancer patients are coming out at later stage, and a significant number of cancer-related deaths happen because of malnutrition. So unintentional weight loss often combined with progressive skeletal muscle atrophy is commonly reported during chemotherapy or radiotherapy treatment. So during active cancer treatment, maintaining the caloric balance is the most important nutritional goal. The need for caloric intake is usually increased during cancer treatment. There has been loss of lean body mass, digestive difficulties, and fatigue are usually temporary but sometimes persist. So especially in India, complementary cancer therapy can bring the optimal outcome of the drugs which has been used to treat cancer. So during cancer treatment, all the chemotherapy agents that are cytotoxic kill the cancer cells as well as the normal cells, thus the patient becomes weak. So if the patient is provided with correct nutrition, this makes the patient more stronger. It will reach the normal cells as well as the cancer cells or tumor cells, but within the period of time, it will help to proliferate the normal cells. So our EON formula is to give the nutrient to the cancer patient, and that nutrients that do not benefit the cancer cells, but only the normal cells. So that's how cancer cells are starved and they are weakened. Hence, we have seen that it gives the adjuvant therapy with the chemotherapy and radiotherapy during the whole cancer treatment. Thank you. Next slide, please. Thank you. Thank you, everyone.
Thank you, Dr. Sajida. So we talk about losing weight during treatment, and that has an impact on the survival. So there are few patients who are going to gain weight. So because of chemotherapy, because of hormonal disturbance during the treatment of cancer. So what is your take on that? So does it also have a survival impact like losing weight?
Sir, actually, we have seen not all the cancer patients are being given ion therapy, but the patients with lung cancer, if you see, or head and neck cancers, if we talk about, we have seen that these patients are suffering from cachexia mostly, and they are malnourished. So, due to some patients get a high amount of stress as well as their physical life is compromised, their family relationship gets compromised, they don't take the ample amount of diet. So they are not able to focus, and and we have also seen that loss of appetite happens in this number of patients. So in that reason, we give this ion therapy. So
Thank you so much. So now we move to the quiz. Siddharth, please get him. So everybody appreciated the Kolkata tea, and thanks to that gentleman. So a big clap for them. आइए हमारे तरफ से थैंक यू सो मच धन्यवाद So now, I can call upon Sri Gopal, Amit, Prakash, Ganesh, so who are all the judges and prepared. So please, yeah. कहाँ गया? क्या नेला पेपर टाइट हुआ? Please come over the stage. So ultimately we had 8 quiz groups, and after the first round, so 5 were selected for the finals today. So the first prize is a 15,000 cash, second is 10,000, and third is 5,000. So we'll start from the third. So it's some hospital, Dr. Santosh and Dr. Sushil. So big clap. Thank you Santosh, Sushil. Second prize, Rudra, come over the stage, but you are not the winner. So second is from the Acharya Harrier, Dr. Manas Ranjan Senapati and Abhishek Sarangi. So big clap for them. अब चलते हैं पहली पदाम पर. So 15,000 cash. Winners are from the Sum Hospital, Abhishek and Antara. Sirupal. Thank you so much, our judges, quiz masters. There have been a great effort. So you can see a multi-talented girl. So Antara, she sang so well yesterday. Please stay back, stay back. And today you can see she is also a winner. So now we move to the posters, e-posters, oral presentations. So lots of efforts by Dr. Sri Gopal, who is a new entrant DM medical oncologist. coming back to home. So a big clap for Sri Gopal, Amit, and Sudham, Ganesh, and also Prakash. So we had 126 entries, and out of which could select 69 e-posters and 21 oral posters. Ganesh, please. Aja, dod ke, please. So among the e-posters, so from the judges, I could get the information that it was very tough to choose one. And it was Dr. Sumitra De of Bose Institute. So polyphenol rich fraction of Bergenia ligulata sensitizes colorectal and breast cancer with high specificity, a mechanistic insight. So congratulations, Sumita. So that was from a virtual. So she will be sent the mementos through a courier. Now coming to the oral presentations. The first was C.K. Kirtana from Rajiv Gandhi Institute of Technology. The presentation was deciphering atorside B mediated modulation of critical signaling pathways in hepatocellular cancers. So congratulations, Kirtana. Thank you so much. So that brings us to the validatory. So after this, so you can please proceed to the lunch. The lunch is being there. And we have come all the way to the end of 4th Indo Oncology Summit. So I understand that there have been a lacunae. So as a part of organization, I take sole responsibility with all my team members. So hopefully when we meet next, so we'll at least make over, close over all those loopholes we have created that may not be intentional, but maybe it needs to be more matured. There are lots of informations, communications that have been lacking and that we understand, and that has costed us also because of giving us so much of effort in a scientific, but still we could not make it. So next time we should have a foolproof planning. If there is no foolproof planning, then we should not do such. So this meeting you have seen so many new faces starting from left, right and center. So right, so Dr. Romila, so I thought that is the best way to introduce her, and she has been really a fantastic host. So all big clap for her. And as I said, so many of our new colleagues have been introduced to this August gathering. And I thank Ranjan and his team, Saroj Babu and his team, and mainly Jyoti and Majumdar from the Padmaja people group. And everybody said the food part, the venue part. So venue and menu has been a 5-star, 5 out of 5 or 10 out of 10 you can say. So our chef is also in the back. So Mr. Sipu, all a big clap for our chef. So without their efforts, so I don't think that it would have been a, if I call it a success or a failure, so it is there. And really, and all those, my colleagues in the Healing Touch group, so who has always been a backbone. And to name a few, so they have been really superb. So be it Siddharth, Shubhasish, Tushar, Biswarup, Satya. So there are n numbers. So I can, and you can see the girl. So Avilipsha, so she has been a strong, a lady going back at 10 o'clock at night. So that is the dedication. So we cannot take away those good part of certain people. So they have been associated, and so that's what matter at the end of the day. So you count blessings, you count good wishes of your colleagues. So that was a phenomenal journey, and all my dear students, so from whom I have been learning rather than they are learning from me, because the medical curriculum which was there 22 years back is totally different. We are in that cancer journey where things at the books are rewritten at this moment. So lots of things are happening. So before we end and meet next time, so stay safe, take care. So there is a viral flu everywhere. So with so much of close approximation in last 3 days, so everybody is going to get back the viral. So get immune. Thank you so much. So Romila, if you say something.
Thank you. Wish I could say something. I'm sorry for my bad throat. Thanking sir, thanking the organizers to having me here. It was a wonderful 3 days spent. Lot of knowledge, lot of interaction, knowing people. Thank you, sir. Thank you, Dr. Viswas. Over to you.
Thank you, everyone. And I think we had a very emotional, valedictory session and address by the Honorable Organizing Secretary and the Master of Ceremony as well. I greet everyone for your support. This conference, I believe, is not a organizer-centric conference. It's also a participant and organizer-centric conference, because at certain times and point we have received maximum cooperation for everyone, from our industrial partners, from our speakers, faculties, organizing committee, everyone at times of need, everyone contributed their effort. And these type of activities and knowledge-centric activities is very much important, because we believe education should not be confounded within the walls of the campuses and colleges. So with this, with his leadership of Dr. Viswas sir, these type of activities are being done so that the current updates in the field of cancer sciences could be imparted to students, young researchers, so that we would make ourselves ready for the next generation with all modern technologies and know-hows. I wish everyone all the best, and thank you very much.
Any comments, Amit?
I don't think it's a failure by any means. I mean, this is a fantastic journey. I mean, for 3 days, we learned a lot from you, sir, and from all the sessions. And only thing we can go from here is even we can attain further heights from the next year onwards. Yeah. Thank you.
Sudham.
This is the 4th time, but I have attended, this is the first time such big, huge conference with many participants all over the country. Like poster presentation and paper presentation was from all over the country. And it was a really good thing to know different branches, not only from allopathy, homeopathy, nutritionist, everybody participated in a huge number. So it is a good start for this type of presentation all over the India. So I think the 5th will be more better than this one. Hope.
So for me, after coming back to my own state after 7 years of journey outside, it's really a pleasure for me to be a part of this conference. Special thanks to Ghanshyam sir and all organizers for giving this opportunity. And really I feel very happy that we are organizing a conference in our own soil and state. We will definitely try harder in the next coming sessions and conferences to do it much better also. And I would thank Ghanshyam sir, and I can see everything is organized very well. All this credit goes to sir and Rudra and all other organizers. Thank you all for great participation.
Actually, my personal growth is much more here rather than conference point of view. I have been for a panelist for a judge. I became judge and speaker and all things I have done. to these conferences. So personal growth is much more. I have seen conferences all over India, but and in Bhubaneswar like this, these conferences is a huge success. So everybody from all over India, I always take the feedback like sir. I was moving in and around. All people are actually happy. So things my conference like should go on, and as per Rudra, the knowledge should not be focused on only campuses, and this should be shared and shared so that patients get the maximum benefits.
Thank you, Ganesh. So while I was busy for the conference, he is the man who took care of the patients at Spurs. So thank you. So, I'll call upon these gentlemen, these ladies, so who has helped us during this conference, please. And Jyoti, so Jyoti is the man, so I thank, so I know him for last 14 years. So Mr. Babu, please, Asan, Mr. Babu. Please, Rudra.
Care units. The 10-bedded emergency and triage unit backed by dedicated intensive care units for brain stroke, cardiac and trauma cases makes the hospital first port of call in case of any emergency. Apollo Hospitals Bhubaneswar meets the demand for neonatology at a various level with 3-level NICU, which is equipped with advanced ventilators and other equipments. The hospital is a teaching institution too, being recognized for postgraduate courses and other various specialities. To meet the growing incidence of cancer, Apollo Hospital Bhubaneswar has also added another feather, the state-of-the-art Cancer Care Center within same premises. The Apollo Cancer Center has Odisha's first and the most advanced linear accelerated radiation machine, the variant TrueBeam STX, to offer the most precise radiation therapy treatment. The center also has a Siemens 64-slice PET-CT machine and is equipped with all modern facilities to do every type of PET-CT, including PET-guided biopsies. The center is in the front runner in providing organ-specific cancer care in the state of Odisha and has a multidisciplinary tumor board committee. Currently, all departments of oncology is running, including medical oncology, radiation oncology, surgical oncology, and nuclear medicine. It is a big part for Apollo to host this 4th Indo Oncology Summit, which was going from 11th to 13th, and we are glad to have you all. So I welcome you all on behalf of Apollo. Now I have to introduce a man who doesn't need any introduction. The man who is internationally renowned figure, and we are luckiest to get some time from learning from the pioneer who has not only taught various students, but also gave inspiration to lot like us. Professor Dilip Kumar Parida, sir. Currently, he is the professor and head of the Department of Radiation Oncology in All India Institute of Medical Sciences. Sir has bagged a lot of international accolades, and he has done a lot of professional training outside, like in Osaka University, Yonbeam Center, Japan, University of Mannheim, Germany, and lot of hospitals like ISRO Fellowship at Denmark, Ion Beam Center, Haigo, Japan, and lot many more, which is not able to be finished in this short span. Sir has a lot of interest in brachytherapy, total skin election radiation, stereotactic and conformal radiotherapy, radiation, cell biology, and cancer genetic. Sir has a very eventful period also in Mumbai to 2008 and the terror attack. So sir has already been an inspiration to all, and we are very lucky to hear you, sir. So I'd like to welcome you, sir, on the stage today. He's going to introduce us to advanced radiotherapy techniques. Sir, please.
Sir, who? Okay, sir. Light, light, pura light.
Good afternoon. Thanks, Dr. Stiti and Sukumar. This is our home, so I don't, so we don't, in fact, need any kind of introduction like this. But anyway, as she told, actually, I always say, actually, I am having 360-degree kind of experience, professional, non-professional also. And the last introduction she gave me, I always actually say proudly because nobody else will compete with me for that experience. That there are facts. The rest everything, everybody will try to compete, but not for the last one. So I am a proud possession of the last one. But anyway, God is very kind, and so that we are actually meeting. And I think 2 days before I was in Delhi, I was talking to somebody. He was saying, why you are not coming to Mumbai? I told him, it may be a coincidence. After that, not a single time I have gone throughout the country, but not to Mumbai. So anyway, I am having the actually pleasant duty of starting the conference. So SRS is the focused one. So I'll give you the 360-degree technical advances in radiation oncology, and then followed by Professor Senapati and the other dignitaries will take you to the focused workshop. So we have actually traveled from 1895-96 from the discovery of X-rays and radium to the linear accelerator, and as our previous doctors and speakers told, the most advanced linear accelerators. So for the students, we ask in the MD examination what is the difference between cobalt-60 machine and linear accelerator. But now the question is actually what is the difference between linear accelerator and most advanced linear accelerator. So the path was not very smooth, but still we have continued the journey of development. And the 1-point agenda I tell students to pass the MD examinations, whether you are watching 100 movies in that period of 3 years or going to 500 picnics, does not matter. But if you are passing the examination and not passing the examination, that is the point. So what is the point in our radiation oncology? That is the how much dose we are giving and how much cells we are killing, the therapeutic ratio. So if you are killing the cells with less dose, we are producing less side effect. If we are killing the cells with more dose, it is our aim and objective to reduce the side effect, which actually the objective of the present today's workshop by doing SRS, large dose, that is actually extreme hypofractionation, SRS, large dose, single fraction. But the objective always remains how much cell we are killing. So anyway, the first journey actually, we are all taught from 2D era, the extreme right one. And right now, we are in the extreme left one. So this is again the scale. So started from the deep X-ray to protons and the most advanced this thing. So these are the actually individual advances you can see. The advances are not in a single field and not in the field of radiation oncology. It is a combination. So there are actually the individual ones, and this gentleman actually, the red revolution and innovation in IT. Without IT, these left-hand advances will be actually the sole advances in their own field. But the revolution in IT sector has integrated each and individual innovations to one, which has given us the advantage to do such kind of procedure like SRS and SVI. Suppose there would not have been actually innovation in the IT field, then again individually, like actually all doctors sitting in the individual clinics, seeing 20 patients, and each individual doctors combining the 20 patients data, it becomes a big data. So the credit goes to IT. So these are actually the, if we can, from 2D, 3D, 4D, what is 4D? 4D is the muscle. If you track the muscle, control the muscle, and deliver the treatment adequately, optimally during that motion period, it becomes the best optimized kind of radiation. So these are the different procedures by which you can track the organ motion and deliver your radiation very safely only to the tumor, not to the other organs. So these are different procedures, how, and this is the example. Normal breathing, your heart comes, this is the breast planning, and the with ABC, you are setting your critical organs. So how this is actually, you track your breathing motions. So now the question comes, how? There is, I told you, there is immense development in the field of actually diagnostic radiation, also diagnostic radiology also. And when we acquire those images and combine to our treatment planning and guided through images, the delivery of radiation through images, that is called image guided, and image guided today is the best possible kind of conformal radiotherapy. Respiratory getting, I have already told, and these actually facilities are to the comfort and convenience of radiation oncologists when they plan particularly the conformal radiation. The latest is the surface guided radiotherapy, where actually the patient positioning and the internal movement tracking is done very precise. So this is surface guided radiation, where the patient surface is totally the coordinates enter into the machine, and the minimum imbalance and this thing positioning problems in the on the couch, that SCRT tracks it. So these are the different advances in our radiotherapy delivery technology. There are the technological improvement to the machines as well as the procedures. So this is the topic of today's workshop, stereotactic, and as I told you, stereotactic radiotherapy is the most extreme hypoplastic kind of radiotherapy, single dose, highest dose, and single dose, for which the immobilization becomes actually very important. If the patient is not properly positioned, patient is not immobilized properly, any kind of actually little movement produces more side effect than the effect. So when we are discussing about actually the conformal and the extreme conformal radiotherapy like SBRT and SRS and SRT, then the immobilization patient position becomes extreme importance. So until unless you are having actually very specific kind of patient immobilization and patient positioning is very strict this thing. So you should not actually try to go into the SRS and SVRT kind of technique. So proton beam, though actually it has become very common outside of India, but still I am happy at least now I think there are already 3 installations and Apollo is the number 1 pioneer in this proton filters. Plus radiotherapy is also there, but I think in our country we have not started yet. But technologies is okay, but in our country the dichotomy is we get patients with all advanced kind of disease. So in the morning we are discussing with Srivastava also. Patient selection and the use of technology is the dichotomy in our country still. So we have to see a balance between this thing. The MR Linac is also a recent one, and for treating soft tissue a tumor inside, the MR Linac is the better one than the simple Linac. This is intraoperative one. So inside OT also, after once the surgeon takes out, we can deliver radiotherapy very precisely to the tumor bed with electrons. Now coming to the imaging facility, the PET has actually made our life much more better because we see the functionality of the tumor. Once we decide and see the functionality of the tumor, then we can target the tumor cell in a better way. So these days, for any kind of conformal radiotherapy, we fuse the CT, MR, and PET to get the best possible optimization. Now we are moving more towards the biological side. Mostly technology actually is having its own curve. So now I think we have attained almost the peak of the technological development in other areas. And when the technology peak and attain a plateau, the biological cell biology is the only way to proceed further. Artificial intelligence is the future. So now we are actually talking about the machine and